And this arrow, as you can see, this line, it is going inside and outside of this page. Okay, perpendicular to this page. Okay, so this upper and lower, this is known as the anterior part. This upper part, which is towards your head, the part towards your toe is known as the posterior part. Okay, the part which is coming out of this page, it is known as the ventral. Okay, this part which is going behind is known as the, what is the opposite of ventral? Dorsal, right?
Dorsal.
Okay. This part which is proximal to your central part of the body, this is the proximal part, and the part which is distal is known as the distal part. Is that clear up to here? What is proximal, what is distal, what is anterior, what is posterior, what is ventral, what is the dorsal?
Yes.
Okay, so with this thing in mind, let's discuss what genes form what parts. Some of them forms the anterior to posterior structures. Some of the genes forms this ventral dorsal structures. Some of the genes form the proximal and the distal structures. So they all takes part in the formation of these axes in your body. Okay, so let's discuss them. Okay, so this is your limb bud. Okay, in your embryogenesis, this limb is gonna be your this limb bud is gonna be forming your hand. Okay, let's suppose this is gonna be your hand in the later stages. Okay, when this is a limb bud, it has certain genes on it. Okay, like at the very apex, as you can see, this is the apical ectodermal ridge. Okay, and this apical ectodermal ridge consists of two genes. One is the fibroblast growth factor gene, and second is the Wnt7 gene. Similarly, at the base of this limb bud, okay, you have a zone of polarizing cells or zone of polarizing activity. Okay, and similarly, you have the Hox genes and other genes. Okay, so let's discuss what is the function of these genes. First is the fibroblast growth factor gene, which is present in this apical ectodermal ridge. Okay, and this fibroblast growth factor gene is responsible for the proximal to distal development. Okay, that means a proximal to distal, which means the length of your limb. Okay, how much your limb is gonna be lengthened, it's all dependent upon the fibroblast growth factor. And if you guys go back to the achondroplasia, we have discussed if this fibroblast growth factor 3 got activated, what you will get is a shortened limbs, remember?
Yeah.
So remember, this fibroblast growth factor is responsible for the limb growth from proximal to the distal. That means the length of your limb is totally dependent upon this fibroblast growth factor gene. Second you have is the Wnt7 gene, and it takes part in the dorsal to ventral development. You know that in that dorsal part, which is coming out of this page, okay, you have the these flexor groups, right? The flexor muscles in the anterior, in the dorsal, right?
Yes.
Sorry, extensor group in the dorsal and flexor group in the ventral, right?
Yeah.
So this Wnt7 gene will decide what structures gonna be on the ventral side and what structures are gonna be on the dorsal side. Okay, it will form the flexor group on the ventral side and it forms the extensor group on the dorsal side. Is that okay?
Yeah.
Yes.
So this is a function of your Wnt7 gene. Okay, and similarly in case of your knees, okay, that dorsally you have the flexor groups and ventrally you have the extensor groups, right?
Right.
Yes.
So that all dependent upon this Wnt7 gene development. Okay, similar to this limb bud, you also have a limb bud for this, for your lower limbs. Okay, and same thing, the Wnt7 gene performed there. So location of these genes very important. They are present in the apical ectodermal ridge, which is in the apex of your limb bud. Then you have the base of the limb bud. In the base, you have the zone of polarizing activity where you have the Schonick hedgehog gene. Okay, and the anterior to posterior development. So if you go from anterior to posterior in your limb, just give me a second. Let me draw this. So this is your limb, okay, and these are your fingers. Okay, so this is the anterior part and this is the posterior part. So what structures are gonna be on the anterior side, what structures are gonna be on the posterior side? It is totally dependent upon the Schonick hedgehog gene. Okay, that means you have this flexion. Sorry, you have the adduction. Okay, whenever your arm goes in this direction, and you have the abduction whenever your arm goes in this direction, right?
Yes.
Yes.
So this totally depends upon this Sonic Hedgehog gene. Your thumb is on the anterior side, right? This is your thumb.
Yes.
No? Let us suppose this is your thumb. Of course, if you make your hand, it's this way. This is your thumb. So your thumb is on the anterior side and the little finger is on the posterior side, right? Towards the lower side. It all dependent upon the Sonic Hedgehog gene. Okay.
Okay.
Yeah.
And you know one more function of this Sonic Hedgehog gene. You know about this holoprosencephaly, right?
Yes.
Where you
Yes.
have a mutation in the Sonic Hedgehog gene, and as a result, you will have the loss of all this sulcis, right, in the brain.
Yes.
Yeah.
So the holoprosencephaly will happen whenever you got a mutation in the Sonic Hedgehog gene. So please note the function anterior to posterior. That means from head to toe. What structures are going to be towards on the head side? What structure is going to be towards the toe side? It totally dependent upon the Sonic Hedgehog gene. Okay. Finally, you have the Hox gene. What structure is going to be at what location? The fact that your limb bud, this limb bud is going to be forming your hand, it dependent upon the Hox gene. Okay, and these digits, you have 5 digits or you have 7 digits or you have 10 digits, it totally dependent upon this Hox gene. So location of every organ in your body, the liver is on the right side, not in your chest, not in your pelvis. Okay, this liver in your abdomen. So the location of every organ, every structure, every limb bud is dependent upon this Hox gene. If you got a mutation, for example, let's suppose you have a Hox gene for the eyes. Okay, and let us suppose a mutation occurs, and instead of eyes you got a Hox gene for this limb bud. So you will see the hands are coming out of your eyes. Okay.
Okay.
Similarly, you have the case of polydactyly and the syndactyly, where you have the multiple, 7 digits, 6 digits, or even 4 or 3 digits, right?
Yes.
So the number of digits or number of, you have 2 limbs. The fact that you have 2 limbs is because you have only 2 Hox genes for the hands. If you have 3 Hox genes for the hand, you will have 3 hands. Okay. So all the number of digits, everything is dependent upon this Hox gene. And I already told you about one thing in the gene, the biochemistry lectures, that, the function of this Hox gene, how this Hox gene works, right? We have discussed that already in the biochemistry. It binds on what side of the DNA? No? The enhancer sequence, remember?
Sorry, which one?
Yeah?
Can you repeat it?
Enhancer sequence. Guys, remember in the biochemistry we have discussed about the enhancer sequence?
Yeah.
And I told
Yes.
you this Hox gene and all of these genes, they ultimately gonna bind to the enhancer sequence. They form a protein, and that protein will bind to the enhancer sequence on the DNA, right? And
Yes.
that's how they takes part in the transcription, right?
Yes.
So that's how these genes work. Okay, so now you know that function of every gene. The fibroblast growth factor gene is responsible for the lengthening. Okay, the Wnt7 gene is responsible for the for the ventral dorsal development. Sonic Hedgehog gene responsible for the anterior posterior development. Okay, Hox gene responsible for your digits and everything in your body, segmental organization of your limb. You have arms proximally and forearms distally. It's all dependent upon the Hox gene. So what structure gonna be at what site? It depended upon what type of Hox gene you had at that location, right? So that's everything about the genes for the embryogenesis. Any doubt, please ask.
No, thank you.
No, thank you.
Now, if you go back again to the biochemistry lectures on the vitamins, we have discussed about the vitamin A, and I told you about the teratogenic effects of the vitamin A, right?
Yeah.
So please note that this vitamin A actually disturbs this Hox gene. Okay, it will increase the expression of the Hox gene. So if the expression of my Hox gene increase, the same Hox gene which were designed to make 4 or 5 fingers, this Hox gene now makes 7 or 8 digits, right?
Yeah.
Yes.
Similarly, the auxin is forming only 2 hands. Okay, now if it becomes super active, it forms 3 or 4 hands instead, right?
Yes.
Yes.
Okay, so that thing gonna happen. And similarly, this auxin is also responsible for the formation of your pharyngeal arches. So because this auxin is responsible for the pharyngeal arches, you will have the effect of the vitamin A is also on the pharyngeal arches, right?
Yes.
So now you can imagine how much toxic this vitamin A is for the child development, for the fetus development, right? And that's why you always avoid the vitamin A in the pregnancy, because it has high teratogenic effects. Okay,
Yes.
Yes.
so that's about the important genes for all the embryogenesis. Any doubt, please ask.
No, thank you.
No,
Could you
thank you.
please repeat the effect of vitamin A?
See, the vitamin A actually disrupts this homeoboxine. It causes the increased expression of this homeoboxine, and as a result, if the expression of this homeoboxine increased, so initially, let us suppose a auxin designed to make 5 fingers only. If the expression of this homeoboxine increased, I will have 6 or 7 fingers instead, right? Yeah.
Yes.
And I
Okay,
told
okay.
you this homeoboxine is involved in every structures you have in your body: the eyes, tongue, pharyngeal arches, limbs, toes, everything. You see, all
Okay,
dependent
so
upon the auxin. Yeah.
yes, thank you.
That's about this homeoboxine. So whenever you give the patient isotretinoin or vitamin A, they will all cause the expression of this homeoboxine, and you will have a digit defects, limb defects, the pharyngeal arch defect. You can have any type of defect in your body if you give the patient isotretinoins or the vitamin A, right? And where does he use this isotretinoins? Anyone remember?
Acne.
Acne.
Acne treatment,
Acne.
yes. And that's why the first aid mentioned, you always need to give the patient 2 methods of contraceptive pills, and before giving the patient isotretinoin, you need to make sure that she has a negative pregnancy test,
Yes.
right?
Yes.
So that's about them. Now you have early fetal development. Okay, at the day 0, you have diffusion of male and female gametes. They form the zygote at this day 0, and when the fertilization occur, you have 2 nucleus and 2 cells, 2 and 2C. Okay, and you have the chromosome number also. Okay, the chromosome numbers, these numbers will double, and you have a 2 different set of chromosomes, right? One from male and one from female, right?
Yes. Yes.
Now, then this zygote divides, and when it divides, you have a 2 and 4C. That means 2 different set, but a total of 4 copies, or 2 different copies, you can say, right?
Yes.
Yeah.
Then these cells will divide. Again, you will get a 2 and 2C. This become 2 and 2C. Then 2 and 4C again. Then become again 2 and 2C, or each of these cells. So you will have a division ultimately. And on the day 4, okay, this zygote become the morula. Okay, and on the day 5, the blastocyst, embryoblast, and trophoblast, 2 structures are formed: embryoblast and the trophoblast. And finally, the implantation occurs at the day 6. And when the day 6, when this implantation occurs, the syncytotrophoblast, which is this layer, the trophoblast is formed the syncytotrophoblast and the cytotrophoblast. Okay, and the embryoblast form all your structures of the fetus. Okay, so on the day 6, when the implantation occur, the syncytotrophoblast begin forming the beta HCG, and this is the beta HCG that we detect in the blood when we do the pregnancy test in the clinic, and this is the same beta HCG that we detect in the urine pregnancy test. Is that okay?
Yeah.
Yes.
So now you see, because the implantation is occurring on the day 6, and and only at this time, the beta HCG can be formed by the syncytotrophoblast. So you can detect the pregnancy only after day 6, right?
Yes.
And
Yeah.
this is a scenario up to the day 6. So within a first week, you will have an implantation, and within 1 week, you will have a secretion of beta HCG. Then in the week 2, okay, this embryoblast form 2 layers, the epiblast and the hypoblast. The function of epiblast is to form the embryo, And the function of this hypoblast is to form the yolk sac. Okay.
Okay.
Then at the week 3, this embryoblast form other layers. Okay, it forms the this ectoderm, mesoderm, and the embryo this endoderm. Okay, and this process is known as the gastrulation. So within week 3, you have 3 layers. Okay, the ectoderm, endoderm, and the mesoderm. Is that okay?
Yeah.
And if you guys go back to neurology again, we have discussed that day 18, you have the start and development of the neural tube, right? And on the day 21, the formation of the neural tube is completed, right?
Yes.
Yes.
But please note that up to week 3, that means at day 21, you only have a development of the neural tube. The neural folds are still open. Okay. Now after week 3, the neural folds start closing, and up to the week 4, okay, or week 8, up to the week 8, you have a full closure of the neural folds. If the neural folds did not close up to week 8, what you will have?
Neural tube defects.
Neural
The
tube
neural
defect.
tube defects, yes. So please note, up to week 8, you need vitamin. What vitamin you need?
Folic.
Folate.
Folic acid.
Yes. You need the folic acid up to the week 8,
Yes.
especially. Because at that time, up to that time, you will have a closure of the neural folds, yes?
Yes.
Okay, so neural tube is formed up to the day 21. That means up to the 3 week. And within 3 to 8 weeks, you will have a closure of neural folds. And this is the only time where you have the development of all the organs. And that's why every teratogenic drug you know, they all act on this 3 to 8 week to form the organ malfunction, organ maldevelopment. So this is the time where your fetus is extremely susceptible to the teratogens, because at that time you have the organ formation, organogenesis. Is that okay?
Yes.
Yeah.
So let's discuss what organs form on this 3 to 8 weeks. On the week 4, you have the formation of heart. Okay, and this heart began beating at week 4, and that so after only after week 4, you can listen the heartbeats of the fetus. Okay. Similarly, upper and lower limb buds form, and we already discussed how these limb buds are forming, right? All these genes are responsible for that. Okay, so the limb buds will be forming on the week 4. On the week 6, okay, you can see the fetal cardiac activity by the transvaginal ultrasound easily. On the week 8, the movement of the fetus starts. On the week 10, you can have the genitalia. So on the after week 10, you can see whether it is a male fetus or a female fetus. Okay.
Okay.
Yes.
So step 1 can ask you about this week 10, very important. Step 1 can ask you about this week 4. This is also very important. They will ask you about this week 3 to 8, about all the teratogenic drugs and the neural folds. Okay, please note on the day 18, you have this notochord that is stimulate the ectoderm to form the neuroectoderm and to form the neural tube. On the week 21, the neural tube formation is completed. On the week 8, you will have a complete closure of the neural folds. So this 3 to 8 week period is very important. Week 4 is important. Week 10 is important. Okay. Week 3 is also very important, where you have the gastrulation process, ectoderm, mesoderm, endoderm. Week 2, epiblast, hypoblast. Week 1, you will have a formation of, you will have the implantation of the embryo. On the day 5, you have the embryoblast and the trophoblast. Embryoblast that forms your epiblast and hypoblast, and finally the epiblast forms your embryo, right?
Yes.
Yeah.
So remember it like that. Initially 2 layers, epiblast and trophoblast. Trophoblast forming the syncytotrophoblast and cytotrophoblast. Epiblast forming 2 layers, this embryoblast forming 2 layers, epiblast, hypoblast. Hypoblast forming the yolk sac, epiblast forming the embryo. Okay, the epiblast forms 3 layers, ectoderm, mesoderm, and endoderm. And that's how you will have a development of all these things. Okay.
Yeah.
So FY21 has changed in 8 genitalia characteristics. Sorry, I didn't understand what you're trying to say here. Okay, 8 weeks. Okay, so you can remember that on the 8 weeks. Okay, you can change it. In the FY21, it has mentioned that, on the week 8, you can detect the male or female, because on the 8th week you can have a formation of genitalia. Okay, it has changed. So you can correct if anyone has FA 2020, they can change it to week 8. Okay.
Okay.
So that's on the week 1, you can have a serum pregnancy test, which you do in the clinic. You will measure the blood levels of the beta HCG. You will get whether the patient is pregnant or not. On the urine pregnancy test, however, okay, it will take time to, because, you have some receptors in your kidney that can cause a reabsorption of all this beta HCG, right?
Yeah.
So this level of beta HCG in the blood need to reach a significant amount where it cannot be reabsorbed by the kidney, right? In order to come in the urine. So, and that happens only after 2 weeks. After 2 weeks, the concentration or the level of this beta HCG is reaches so much that all the transporters is become saturated now. And at that time only, you can have this beta HCG in the urine. So only after 2 weeks, you can detect this beta HCG in the urine pregnancy test. So please note, for the clinic, you measure the blood samples, and that can be done after 1 week. In the home pregnancy test, you can have a positive results only after 2 weeks of the pregnancy. Is that okay?
Yes.
Yes.
So that's everything on this page. Please ask if you have any doubt.
While urine pregnancy test is positive after 2 weeks, can you repeat it?
What was the question again? Please repeat it. Your voice is not very much clear.
Urine pregnancy test is positive after 2 weeks. Can you repeat why?
You want to know why we are doing this pregnancy test is 2 week, right?
Yeah.
See, what happens is, on the week 1, you have the start formation of this HCG, right? From the sincere trophoblast, right? Then the concentration of this beta HCG is slightly increased. Gradually, it is increasing. On the day 2, on the second week, after the second week, the concentration is reaches so much that you have all the transporters in the kidney saturated. Now you cannot have the reabsorption of this beta HCG in the kidney, right?
Okay.
So then only you can have this beta HCG in the urine, and that's when you will detect this HCG in the urine by the home
I got
pregnancy
it.
test, right?
Thank you. Yeah.
So any more doubt on this page, please ask.
No, thank you.
So what is the status of your oocytes? 2 and 2C or 1 and 2C or 1 and 1C?
1 and 2C.
1 and 2C, yes. Okay, do remember this also. Yeah, in the serum, we can detect the beta HCG within 1 week, because as soon as you since that trophoblast begins secreting the beta HCG, it can be detected in the serum, right? But to come in the urine, okay, in order to detect this beta HCG in the urine, you need to wait for at least 2 weeks before you can detect this. Yes. Okay, so your oocyte is 1 and 2C. Okay, that is the important thing. And when it becomes fused, you will have a 2 and 2C. Okay. Just give me a second. Yeah. Now let's develop what structures are formed from your ectoderm, what structures form from mesoderm, what structures form from endoderm. You don't need to remember every structure, just some exceptions you need to remember, because most of these things are obvious. So you need to remember what exceptions are there. So for the ectoderm, you have 3 things: the surface ectoderm, the neural tube, and the neural crest. Okay. And you guys know how this neural tube are formed from the surface ectoderm, right? this ectoderm will change into neuroectoderm, and then this neuroectoderm form the neural tube and the neural crest. Remember?
Yeah.
So now, on the surface ectoderm, okay, it lines your oral cavity. Okay, so important thing is this ectoderm lines your oral cavity, and almost everything that you can see on the outside, it is all formed from the surface ectoderm, the epidermis, and you guys know about the Rathke's pouch, which is an extension of the oral mouth, the roof of the oral cavity, right?
Yes.
Yes.
So that and this Rathke's pouch, this forms your adenohypophysis, right? The anterior pituitary.
Yes.
So this anterior pituitary is derived from the Rathke's pouch, which is a surface ectoderm again. Okay, the lens of the eye that you can see from outside, it is all made up from the ectoderm. Similarly, the epithelial lining of the oral cavity, sensory organs of the ear, olfactory epithelium, anal canal below the palatinate line, parotid, sweat glands, mammary glands. These all things are visible on the outside, right?
Yeah.
So all these structures that you can see externally, it is all made up of the ectoderm. And you know about the scleropharyngioma, which is a tumor of the Rathke's pouch in the child, right? It is all
Yes.
from the surface ectoderm tumor. Then you have the neural tube. Okay, all the CNS structures that you know, all these structures in your brain, the upper motor neurons or the oligodendrocytes, the astrocytes, right?
Yes.
Spinal cord, retina, pineal gland, all of these things are formed by the neural tube. Okay. For the neural crest, the peripheral nervous system and all the nerves which are lined by the Schwann cells, these are formed by the neural crest, right? The melanocytes S100, remember?
Yes.
Yes.
So melanocytes, odontoblast forming your teeth, tracheal cartilage, okay, the enterochromaffin cells, okay. And what is the function of these enterochromaffin cells? Remember?
Histamine secretion.
Yeah, histamine. Not the enterochromaffin cells, histamine act on these cells, right?
Uh,
Serotonin.
Not the serotonin.
Gastrin.
Yeah. Say it.
Gastrin increases the secretion through.
Yeah, oh, sorry, I got confused, I think. Yeah, actually, the gastrin act on it, not the histamine. Sorry about that. You were right. Okay, gastrin acts on these cells to release the histamine, right?
Yes.
Yeah, okay. I got confused. So from the G cells, you have the gastrin release. The gastrin that acts on this these cells, the enterochromaffin cells, to release the histamine, and then both the gastrin and the histamine, they act on the proton pumps to release the acid, right?
Yes.
Then the leptomeninges, the this arachnoid and the pia mater, these are formed by the neurocrist cells. The peripheral nervous system ganglions that you guys know, it is all formed by the neurocrist cells. Okay, adrenal medulla, okay, which is this structure, the neurocrist structure. Schwann cells again, spinal membranes. Okay, spinal membranes are formed by this, and you guys know about this aorticopulmonary septum. I told you the neurocrist cells has to reach there, right?
Yeah.
Yes.
And then this spiraling will occur, this endocardial cushions take part in it, right?
Yeah.
And
Yes.
these endocardial cushions are also derived from the neural crest. Okay, skull bones, they are all derived from the neural crest. So most of these things you already know. Okay, the important ones are the tracheal cartilage, enterochromaffin cells, okay, the endocardial cushions, skull bones, and the aorticopulmonary septum. These are the important ones that you must remember. Rest all are the obvious thing. You have already studied about all of them, right?
Yes.
Now you have the mesoderm, okay, and for the mesoderm you have the muscles, bones. What bones? Except the skull bones, every bone is formed by the mesoderm, okay. And there's the dura mater is also formed by the mesoderm, okay. Arachnoid and pia by the neural crest. Dura mater is by the mesoderm, okay. The serous lining of the body cavities, the peritoneum, pericardium, pleura, these are all formed by the mesoderm, and that's why the spleen is also a mesodermally derived organ, remember, because it is formed by this peritoneum of the stomach, right?
Yes.
Yeah.
So remember the spleen. Rest all of the GI structures are derived from the endoderm except the spleen, which is a mesodermal derived tissue. Okay, so spleen, which is derived from the foregut mesentery, it is formed by the mesoderm. Okay, the cardiovascular structures, all the blood vessels, you know, the heart, everything is formed by the mesoderm. Okay, the wall of the gut tube, it is also formed by the mesoderm. Lymphatics, blood. Okay, upper vagina part is also formed by the mesoderm. Kidney formed by the mesoderm. Adrenal cortex, dermis, testes, ovaries, microglial cells in the brain. Remember the macrophages.
Yes.
So all the blood cells, all the blood products, they are all formed by the mesoderm, no matter where they're found. Okay. Notochord induces the ectoderm to form the neuroectoderm. I told you that form the neural plate. Okay. And the remnant of it is this notochord is known as the nucleus pulposus. Remember?
Yes.
So that about the mesoderm. And please note, whenever you have a defect of the mesoderm, you also have the association defects. That means, you know, you cannot have an isolated defect. It must be associated with other defects also. Like you get a vertebral defects, anal atresia, the cardiac defects, the tracheoesophageal fistula, renal defect, limb defect. Whenever you see, you know, 2 or 3 defects of them associated, you will call it a association defect. So step 1 will give you a patient having 2 or 3 of these defects. Okay, and they will ask you what kind of a defect they are. So you need to remember that it is a association defect. Is that okay?
Yes.
So remember the mesodermal structures. The important one are basically the all these lining, the peritoneum, pericardium, pleura. Spleen is very important because, you know, it got a blood supply of the stomach, of the endodermal organ, but ultimately it is derived from the mesodermal structures. Okay, the testis, ovary, vagina, these are also very important to know. Rest all structures you already know about the adrenal cortex, kidney, you know, your heart. All these organs are formed by the mesoderm. For the endoderm, remember every GI organ that you know, it all drive by the endoderm. Okay, up to above the this pectinate line. Okay, all these things are derived from the endoderm. Urethra is derived from the endoderm. The lower vagina is derived from the endoderm. Okay, which is derived from the urogenital sinus. Okay, the lumen of the epithelial derivatives like the lungs, liver, gallbladder, pancreas, eustachian tube, thymus, parotid, the parathyroid, thyroid follicular cells, and the parafollicular C cells. They are all derived from the endoderm. Remember about the thyroid development? First, you have the
Yes.
outpouching from the foregut, and this outpouching then form the complete thyroid. Similar thing goes with the lungs also. And that's why you have the tracheoesophageal fistula, right? Because these two membranes must be separated. Remember?
Yes.
So initially you have the lung bud and you have the bud for the thyroid gland. Okay, and these two buds are derived by the endoderm only from the foregut. Okay, so both the lungs as well as your thyroid, they are all the foregut derived structures. So they are lined by the endoderm. So thyroid follicular cells, thyroid parafollicular C cells, okay, the gland which is present just behind the thyroid, which is the parathyroid, thymus, okay, lungs, okay, and all these structures of your GI tract, they are all formed by the endoderm. Is that okay?
Yes.
So that's about all the structures which are formed by different embryological structures. See, tracheal cartilage is different thing, but trachea has other structures also, right?
Yes.
So tracheal cartilage is different and rest of the trachea is different. Okay, it has muscles, it has many things.
Yes, sir. Thank you.
So, and in doubt, please ask.
No, thank you.
Okay. So now you have different type of defects in the morphogenesis, and step 1 will give you a defect in the patient, and they will ask you what kind of a defect this patient is having, whether it is a agenesis or a aplasia or a hypoplasia, disruption, deformation, malformation, sequence. Okay, so you need to know the examples of them also. So the first one is the agenesis. Okay, And the agenesis occur whenever you have an absent primordial tissue. For example, the renal agenesis. Okay, whenever you have the organ absent, and that is because of the absent of the primordial tissue, you call it a agenesis. If you have a primordial tissue, even then you're having a absent of the organ, you call it a aplasia. For example, a thymic aplasia, remember?
Did
Yes.
George.
And where will you have the thymic aplasia?
Did George.
The
DiGeorge
DiGeorge syndrome, yes. So remember thymic aplasia, you call it a aplasia because in that case you're having the primordial tissue, but you're not having the organ there. Third you have is the hypoplasia, where you have kind of a atrophy, or you can say an incomplete development of the organ happen. Like the microcephaly, for example, that is known as the hypoplasia. Okay.
Yeah.
Yes.
So that primordial tissue is present, but you're having an incomplete organ. That is the hypoplasia. Then you have the disruption. Okay. You are having a normal tissue present. This tissue, the primordial tissue is normal. It is present. It is forming this structure normally, but due to some external forces, you're having a disruption of this formation. For example, the amniotic band syndrome. Okay, in which the amniotic tissue, okay, this fibrous, it forms a fibrous tissue around your this limb. So the limb is forming, organ is there already because the primordial tissue is present, but due to some external forces, in this case the fibrous tissue, it is disrupting the formation of this normal organ or normal structure. Okay, so whenever you encounter a patient having a ring-like structure on their arm or on their this abdomen or on any of the limb, you will think about the amniotic band syndrome, and that happens because of the disruption. Is that okay?
Yeah.
Yes. Thank you.
Then you have the deformation. Okay, and that happens because of the crowding. For example, you know, this club foot deformity that you see in the sequence defect. Remember the Potter sequence? Remember? I told you because in the sequence you're having a decrease in the cushion for the fetus. You will be having this defects in the extremities, right? The club foot deformity. Remember?
Yeah.
Yes.
So this kind of a deformity can also occur in absence of sequence, where you have some kind of a crowding. Okay, and that can lead to the disruptions. For example, a torticollis you have. Okay, the cleft foot deformity. In the cleft foot deformity, this is what your feet look like. Okay, the plantar flexion will be there. Okay, and the foot will be medially derived. You know, it is a kind of thing. Okay, and let me draw this for you. If this is your midline, okay, this is a midline part. This is your lateral part. Okay, you have this abdomen here, and similarly, this other limb is also here, right? So as you can see, you're having a plantar flexion in the foot, and this foot is medially deviated. Okay, as you can see, so a medially deviated foot and the plantar flexion, you call it a cleft foot deformity. It happens, and you call it a deformity because you're having a deformation here. Okay, so whenever you think about the crowding, for example, multiple gestations can happen, and that can lead to the crowding, and that can lead to the foot deformities. The torticollis, and does anyone know what this thing is? Torticollis?
The neck gets
Sternocleidomastoid.
deviated to one side.
Yeah, you're having some kind of a spasms in it, right? Just like your tetanus
Yeah.
and dystonia, remember?
Yes.
Yeah.
Contraction.
So the dystonia can thing happen, and that happens because of the extensive deformation, because of the deformation of the organs. Is that okay?
Yes.
So whenever you see
Specifically
about, yeah,
sternocleidomastoid muscle specifically.
sorry,
Sternocleidomastoid muscle.
I couldn't understand. Repeat it again, please.
Specifically in a sternocleidomastoid muscle torticollis occurs.
Yeah, yeah. Okay, so that was one, and that was about this deformation. So amniotic bone syndrome, remember the disruption, the cleft foot deformities, okay, the torticollis, remember that deformation. Then you have the malformation, where an intrinsic disruption occurs. For example, the neural tube defects, the cleft lip, palate, AST, VST. Okay, you don't need any external force for that, right?
Yes.
It is all due to an intrinsic disruption, and we call it a malformation. So null tube defects, cleft lip palate, AST, VST, these are all the examples of a malformation defect. Then you have a sequence. In the sequence, one event lead to a multiple events. For example, the Potter sequence. In the Potter sequence, the loss of the amniotic fluid, which is leading to a loss of cushions, it lead to a extrinsic, all this, the cleft foot deformity, remember?
Yes.
All this lung hypoplasia you're having. So a one defect only is leading to, a one event is leading to other multiple events. And it's all happening in a sequence, and that's why you call it a sequence defect. So the Potter sequence for the sequence defect, remember that also.
Yes.
So step 1 will give you all these examples, the renal agenesis, thymic aplasia, or this microcephaly, or maybe the amniotic band syndrome, or the cleft foot deformity, okay, the torticollis, or maybe AST, BST, or maybe the Potter sequence, and they will ask you in under what category you put these defects. So you need to choose between all of them, okay? So remember the examples, remember the name. Any doubt, please ask.
No, thank you.
So that was about on everything on this page. Just give me a second. In the Potter sequence, you're having a multiple symptoms, right? You're having cleft foot deformities, you're having the, this external limb deformities, lung hypoplasia, cleft lip palate,
Yes.
okay, this microcephaly, anything can happen with the Potter sequence, right?
Yes.
Similar thing is happening in the syndromes also, like the Down syndrome. You're having multiple organ involvement, multiple system involvement, multiple symptoms are there, right?
Yeah.
So how can you differentiate between a syndrome and a sequence?
A sequence will it'll start at one point, and all the all the resultant features will be a result of that particular activity. Like for example, if there is oligohydramnios because of low urine production, it will lead to other things. But in Down syndrome, we are not sure about the pathogenesis very well.
We are sure about the pathogenesis. We are having a mutation in the chromosome that leading to these things, these symptoms. Multiple symptoms again.
Yeah, but
Yes,
like we cannot explain ASD and VSD as a result of Down syndrome.
Well, that happened because of the mutations again in the chromosome. This chromosome is doing everything, right? So we're kind of shocked.
Mainly in the syndrome that all the symptoms or all manifestations because of one mutation or one cause, but in the sequence something results as another something.
Yeah, exactly. See, you have one defect, for example, the Down syndrome, which is a mutation, and this mutation alone is leading to a multiple things. Okay, the ASD, BSD, okay, and this is a tumor. This could be tracheoesophageal fistula, right? This could be your Alzheimer's disease. This could be your eye defects and other defects, right? So this one defect is leading to multiple other defects. Okay.
Yes.
Yes.
In sequence, you first have one defect, for example, the oligohydramnios. This defect is leading to a other defect, which is the loss of cushion. Now, this loss of cushion is leading to other defect, which is a limb deformity. Okay. So as you can see, a sequence is forming. One defect is leading to other defect. This other defect leading to other defect. So this is a sequence, and this is a syndrome.
Okay.
Okay. This is a difference between sequence and the syndrome. Do remember that also. Although step 1 won't ask you this fact, but just for general knowledge. Okay.
Thank you.
Okay, so now you have teratogens, and I already told you the organogenesis happens between 3 week to 8 week, right? So at that time, the fetus is very much susceptible for the teratogenic effects of all these drugs, right? We're going to discuss now. So after 8 weeks, okay, you can have, the hypoplasia of the organ maybe, okay. So, but between the 3 to 8 week, you can have the deformity of this organ. And before 3 week, if you give the patient any drug, any teratogenic drug, you can either form that organ normally, or you won't form that organ at all. So before 3 week, it's all or none law. You either form that organ, which is absolutely normal, or you cannot form that organ at all. Agenesis complete happen. Between 3 to 8 weeks, you will get the teratogenic effects, the organ maldevelopment. After 8 weeks, you can have a hypoplasia of the organ if you give these patient teratogens. Is that okay?
Yes.
Yes.
So let's discuss what happens between 3 to 8 weeks. First, you have the ACDM test, and I already told you can have a oligohydramnios because of that. Because these drugs are acting on the kidney, you can have all the renal defects because of that. The renal dysplasia can occur, renal failure can occur, oligohydramnios can occur, right? So that's about the ACDM test. Then you have the alkylating agents, okay? And they can lead to the absence of digits, multiple anomalies other can happen. You need to remember that. Just know this alkylating agents, just like any other chemotherapeutic agent, they are teratogenic. Third, you have the aminoglycosides. We have discussed that you can have a ototoxicity because of that, and that's when to avoid these drugs in the pregnancy. Anti-epileptic drugs, they can cause, most importantly, the neural tube defects, and that's why you need to give the patient folate supplement whenever you're giving them the anti-epileptic drugs. Okay. If we have a patient who is having a bipolar disorder and she's on lithium therapy, you need to switch the patient from lithium to the anti-epileptic drug, right? Because lithium is more teratogenic than these drugs. And while you're shifting the patient on these drugs like the valproate, for example, you always give them the folate supplement, right?
Yes.
So step 1 can ask you this fact also. You got a patient who was on a lithium therapy, and now you're switching the patient on the valproate therapy in the pregnancy. They will ask you, why is this so? And what other things you should give to the patient along with the valproate. So it will be the folate supplement, when why you are giving this to prevent the neural tube defects, and why switching from lithium to anti-epileptic to prevent the Epstein anomaly, okay?
Yes.
Similarly, cleft lip and palate defects can happen, hyperplasia, facial dysmorphism, like again, this cleft lip palate can happen. And if you guys remember about the phenytoin, the fetal hydantoin syndrome, remember?
Yeah.
Where you
Yes.
have this nail defects, cleft lip and palate defects, and other defects also. Okay, so failings, nail hyperplasia, all these things can happen with the anti-epileptic therapies. Then you have the DES, diethylstilbestrol, which is given, and initially it was given as a supplement, or you can say as a replacement of the estrogen. Okay, but soon it was discovered that it can cause the teratogenic effect. Okay, it can cause the vaginal clear cell adenocarcinoma. Okay, normally you have the squamous cell carcinoma in the vagina, right?
Yeah.
So how you can have an adenocarcinoma? Anyone?
How we can have adenocarcinoma in the vagina? I don't understand the question.
Yeah, normally we have the squamous cell carcinoma because we have the squamous cells in the vagina, okay?
Okay, so maybe metaplasia occurred before adenocarcinoma.
See, actually it was opposite. See, what happens is the outer vagina is formed by the, the action of the estradiol, the estrogen. Okay, it forms the external structures like the external vagina, labia, clitoris. And then
Okay.
you have the Mullerian duct forming the inner part of the vagina. Okay.
Yes.
Now, when the Mullerian duct forms the vagina, it forms the columnar cells there. Okay. And when the
Okay.
estrogen forms this vagina, it forms the squamous cells there, outer side. So on the outer vagina, you have the squamous cells. On the inner vagina, you have the
Columnar cells.
Yeah, exactly. When you give the patient DES, okay, so now what happens normally, all these columnar cells will be replaced in the later stage by these squamous cells. And this is normal. Okay, so that's why in the vagina, up to the outer part of the cervix, you have the squamous cells only in a normal patient. But when you give the patient DES, then instead of this replacement, you cannot have the replacement there. Okay, and the columnar
Okay.
cells will remain the columnar there. Okay, and
Okay.
that's how you can have an adenocarcinoma in the vagina.
Okay, thank you very much.
So remember about the DES, and that's why this drug is now banned. Initially, it was given as a replacement for the estrogen. Now you have the fluoroquinolones, and I told you you can have a cartilaginous damage because of that. Okay. Similarly, for the tetracyclines, I told you about the decoloration of this teeth. The yellowish teeth will be happen, and the bone growth will be affected if you give the patient tetracyclines. So that's why it need to be stopped. Folate antagonist, you all know about the antiepileptics, the trimethoprim, methotrexate.
Yes.
They all can cause the neural tube defects. And not just these drugs, you can also have the anti-cancer drugs, remember? Other anti-cancer drugs can also lead to these defects. Isotretinoins, I told you about this HOX, right?
Yes.
So multiple
multiple-
defects can happen because of that. Yes. Lithium can lead to the abstinence anomaly. And what's the abstinence anomaly?
Like ventricular
Atrialization.
hypoplasia.
Yeah, you will be have a atrialization of the ventricles.
Atrialization.
Yeah. Then you have the methimazole. Okay. And I told you when you give the patient thyroid replacement, the anti-thyroid therapy, I told you initially you give them the PTU, right?
Yes.
But after the first trimester, the PTU will be replaced with the methimazole, right?
Yes.
Because
Yes.
initially when you give the this patient, if you give the patient methimazole in the first trimester, then the patient can have a tetragen or this all these things like this aplasia of cutis, absence of the skin over the scalp, and do you guys remember any other disorder where you can have a aplasia cutis?
Monocephaly, trisomy 13.
Yeah, that time was the 13 trisomy, right? And what is it called?
Patau syndrome.
Down syndrome. You can have a aplasia cutis there also, right? So that's why you need to stop this medication in the pregnancy in the first trimester. You give the patient PTU because it is not teratogenic. However, PTU has a strong hepatotoxic effect, and that's why as soon as this organogenesis is completed after 8 weeks, or you can say after one trimester, you will switch the patient back to the methimazole therapy. Okay.
Yes.
Why we cannot stay on BTU?
Hepatotoxic effect. It can damage the liver also. That's why.
For the mother.
Yeah, in the mother. So that's why
Okay.
first you protect the baby and then you protect the mother. Okay.
Okay. Yes.
Then you have the tetracyclines, discretional teeth. We know that. Thalidomide, it can cause the phocomelia, where you have the seal-like limbs. Okay. And that's where this drug is not stopped. Warfarin is again a teratogenic, and that's why you cannot give the warfarin to a pregnant female. Okay, you can have a stippled epiphysis. Okay, where you see this kind of these defects, although not very much important. Okay, nasal and limb hypoplasia can also happen. Optic nerve atrophy can happen. So all these things because of the warfarin. So all these drugs are basically teratogenic. Important ones are the anti-epileptic drugs, aminoglycosides, ACE ARBs, DES, other antibacterial drugs. They all are very important. Antibacterial ones are the most important ones, like the aminoglycosides, fluoroquinolones, tetracyclines. Lithium, you guys already know. Isotretinoin, you guys already know. Okay. Methimazole, they will ask you why you're switching the patient back to the methimazole in the pregnancy to prevent the hepatotoxicity. That's why this methimazole is important. Rest all you can forget. Doesn't matter. Okay.
Yes.
Okay. Thank you.
Then you have other than the tetragens, you also can have a substance abuse in the female, like the alcohol or the cocaine or the smoking or other substance abuses, and they can affect the development of the fetus also. For example, in the alcohol, you can have a fetal alcohol syndrome. We will discuss that shortly. In the cocaine, you can have a low birth weight, premature birth can also happen. Okay, and because of the cocaine, you can have a vasoconstriction. And when the vasoconstriction happen, you cannot have a oxygen and other nutrients supplied to the fetus, right?
Yes.
Yeah.
And that's why patient will be low birth weight. Okay, malnutrition can happen in the fetal life also. That's why this low birth weight. Preterm birth can happen because of this loss of blood supply. So patient can have a abrupto placenta also because of that, right?
Yes.
Okay. The vasoconstriction and the placental vessels.
Yeah, exactly. The vasoconstriction, the placental vessels happen.
Okay.
So a decreased supply of all the nutrients. That's why a low blood this low birth weight. preterm birth and placental abruption happen because of this vasoconstriction, because of loss of blood supply to the placenta. It will detach from what layer?
Uterus.
From the
Endometrium.
uterus. Yeah, endometrium, right? So that's why you will have a placental abruption in case of cocaine also. Smoking can cause a low birth weight. Okay, again, because with the smoking, you have more this carbon monoxide, low oxygen, and that can lead to impaired oxygen delivery also. Vasoconstriction again can happen, and that's why all the effects which are seen with the cocaine can also be seen with the smoking. The low birth weight, the placental problems like the placental abruption can also happen. Preterm labor can happen, ADHD can happen, sudden infantile death syndrome can happen. We will discuss all the effects of the smoking shortly in the next page, I think. So remember, the sudden infant death syndrome is very important. Within 1 year after delivery, if the mother smokes cigarette around the patient, around the infant, okay, then the infant can have a sudden infantile death syndrome. We will discuss that shortly. Other ones are the iodine. You can have a goiters or the hypothyroidism because of that if you lack the iodine. Maternal diabetes is important. You can have multiple effects because of that. One is the caudal regression syndrome, where you will have a fusion of the legs. And remember, and imagine about the mermaids. Okay, that's what you see in the caudal regression syndrome. You won't have the pelvis of the patient. Okay, you will have the absence of the sacrum in the baby. Both the limbs, both the lower limbs will be fused. So just remember a mermaid. You will know what this caudal regression syndrome is. The cardiac defects like the VSD can happen. Transposition of great vessels can happen. Neural tube defects can happen. Macrosomia, which is a large this weight of the baby at a time of birth, more than 4 kilos birth weight is call it a macrosomia. So why this macrosomia is important?
Obstructed labor can occur.
Exactly, obstructed labor can occur because of, the size of the fetus is now very much big. Okay, so obstructions can happen at the time of labor, and that's why cesarean section is the only option for a macrosomic patients. Okay.
Yes.
And then the neonatal hypoglycemia can also occur. And if you guys go back to the MSK part again, we discussed about all this Klumpke paralysis, right?
Yeah.
And the UBS paralysis, the Klumpke's paralysis. And I told you in the UBS paralysis, it happens whenever, at the time of delivery, and it is because of lateral traction of the neck, right? When you pull the baby from the neck, you can have the UBS paralysis.
Yes.
And that's exactly what happens in the macrosomic fetus. Okay. Similarly, the Klumpke's paralysis can also happen because of a macrosomic fetus. That's why this macrosomic thing is very much important, because it can lead to other defects at the time of delivery. The neonatal hypoglycemia can obviously, what happens whenever you have a high this glucose load in the fetal circulation, then the hyperplasia of the islet cells in the pancreas happen. Okay, and when the hyperplasia occurs, okay, the function of this is to maintain a normal glucose in the fetus, right?
Yes, so will hyperinsulin secretion.
Yeah, so you will have a very high insulin secretion. Now, after the birth, okay, when the glucose level suddenly drop because you're no longer attached to the female, okay, so the blood glucose level suddenly drops, but you're already having a hyperplasia in the pancreas. So a high insulin level with a low blood glucose level, that can lead to a profound hypoglycemia. And it happened only transiently after 1 or 2 weeks or after 1 month after the birth. Okay, you will again get the atrophy and you will get again a normal level of insulin. So within 1 month, you will have a normal symptoms, normal thing again. So a transient neonatal step one will ask you whether it is a transient or whether it is a permanent. Please note it is always a transient. You can mention it here. Transient neonatal hypoglycemia occurs. Polycythemia can also occur because of that. Okay, so respiratory distress syndrome, NRDS can also happen because of maternal diabetes. Okay, you will see that later in the respiratory part. We will discuss the NRDS, and you know that this NRDS can also happen because of maternal diabetes. Okay, and it not only that.
Somebody's asking why polycythemia on the chat box.
Oh, why polycythemia is occurring? I really don't know why it is occurring. Sorry about that. Just remember like that, happening. Okay, now you have the methyl mercury, and that can lead to the neurotoxicity. Delayed milestones will be seen. All these milestones we will discuss later. If you give the patient methyl mercury, you can have a delayed milestones. It can be found in the swordfish, shark, okay, the tilefish. Okay, so remember, you always need to avoid the fish eating in the pregnancy because it can lead to the neurotoxicity in the fetus. Vitamin A excess, we have discussed. If you have multiple birth defects, spontaneous abortion can happen. Cleft lip, palate, limb deformities, okay, all these pharyngeal arch deformities, anything can happen with the vitamin A excess. Accidents, patient can have a microcephaly, intellectual disability, and that's why whenever you want to perform the X-ray, you always does that in the lead shielding. Okay, very important. So any doubt on this page?
I think the polycythemia is because of chronic intrauterine insufficiency because of high glucose.
Because of high glucose, what?
The polycythemia is because of chronic hypoxemia, intrauterine hypoxemia from having high glucose.
Maybe because of high glucose, you're having, increasing number of cells. Yeah,
yes.
The number of cells will be increased and they will lack the oxygen. So yeah, that could be a thing. Yeah, that could be again an answer. Yes.
Thank you.
So note, you can have, because of this diabetes, the cells number will increase, will get a hyperplasia, and that's why you're having the microsomia, right? Now, when the cell number increase, when the hyperplasia occurs, the cells become hypoxic. They need more oxygen. So for that more oxygen, they need to increase the number of cells. And that may be a reason why you get the polycythemia because of maternal diabetes.
Yes.
Then let's discuss the fetal alcohol syndrome. Okay, it is seen in all the mothers who drink alcohol in the pregnancy, right? And this is the most common preventable cause of the intellectual disability. Very important. It is a leading preventable cause of the intellectual disability. Step 1 can ask you this line, that what is the most leading preventable cause? It will be the alcohol. You need to remember that. You need to remember all these features, what you will see in the patient who is having a fetal alcohol syndrome. One thing you will have is the microcephaly. You will have a small brain. Okay, small palpebral fissures will be seen. Okay, if you look in the eyes, this is the palpebral fissures. They become very much small. Okay, and remember where you have the this upslanting palpebral fissures?
Down.
The Down syndrome, in which you're having this, in the Down syndrome, you will see this kind of a palpebral fissures, right? This kind of eyes they have. So this is the upslanting palpebral fissures, which you will see in the Down syndrome. Small palpebral fissures will be seen in the fetal alcohol syndrome. Is that okay?
Yes.
You will have a low nasal bridge. Low nasal bridge will be seen. Okay, or you can say a nose hypoplasia occur because of this alcohol. Okay, upturned nose will be seen. Okay, you have a upward pointing. This upward pointing of the nose will be seen. Okay, a smooth philtrum will be seen. Generally, we have if you see a normal philtrum, it will be like that, right? They have this kind of a depression in the center. In these patients, they have a very smooth philtrum like that. Okay, no depression. Okay, a smooth philtrum will be there. Thin vermilion border will be there. Their lips become very much small, very much thin. Okay, they have an underdeveloped jaw. Okay, mid-face hypoplasia, and that's why this low nasal bridge will be seen. Okay, and yeah, that will be the things you will see in the fetal alcohol syndrome. Other than that, they can also have a ADHD. Okay, they can have a hyperactivity. They can have a high this hitting thing, or this distractibility can also happen. So behavioral things will be there. You will encounter a patient having a ADHD, or maybe having some kind of a very aggressive they could be, right? Most often they will most often you will see the ADHD case. So whenever you see a patient having ADHD, you will do the examination. You will check whether the patient has a history of alcoholism in the pregnancy. On the examination, you will find these kind of features. Okay, then you will diagnose them with the fetal alcohol syndrome, not the primary ADHD. Okay.
Yeah.
So most commonly you will encounter these patients with the ADHD with some difficulties in the distraction, in the focusing, in the hyperactivity, in the hitting. So these kind of things will be there. Other than that, we have discussed all the effects of the alcohol. You can have a holoprosencephaly, which is a severe form. Okay, you can have a heart lung defects, fistulas can happen, limb discolorations can also happen, dislocations can also happen, right? But most important ones are the facial abnormalities that you will see. Any doubt, please ask.
No, thank you.
Okay. Then you have the neonatal abstinence syndrome, and that is seen in the mothers who takes morphine or any kind of a opioid in the pregnancy. Okay. Then after what happens is when they take the opioids in the pregnancy, the child will become dependent on these opioids, right? And just like any other patient who's now getting a withdrawal from these opioids, when the delivery occurs, okay, the level of these opioids will be decreased in the fetal circulation, right?
Yeah.
And that causes a
Yes.
withdrawal symptoms. The most important thing is basically the babies become very much irritable. They have this persistent cry, very loud cry. Okay, they'll be crying for like hours or throughout a day. So whenever you see a baby, okay, who is crying persistently, who is irritable persistently, you will always ask you why this baby is so crying and why this baby is so irritable. And the answer could be a neonatal abstinence syndrome. Other than crying, they will have the sneezing. Okay, they will have this diarrhea, could be, which is again a withdrawal effect. They can also have a tremors. So whenever you see a baby who is crying persistently, very loudly, having sneezing, okay, having tremors or diarrhea, you will always think about the opioid withdrawal. The two major ones are the sneezing and the crying. This is the most commonly you will see. So a baby who is sneezing and crying persistently in a very loud voice, okay, you will think about the neonatal abstinence syndrome. Is that okay?
Yes, thank
Yes.
So the treatment will be to give the patient long-acting opioids, that is the methadone, and then you will slowly taper the dose of these opioids to get a withdrawal in the patient. Okay, buprenorphine can be given. And does anyone remember what kind of a drug it is? Buprenorphine?
you.
Antagonist, right?
Arbitrary.
Yeah.
Partial agonist.
Partial
exactly.
agonist activity.
Yeah, exactly. It is a partial agonist. I was testing you. Okay, morphine full agonist, methadone again a full and a longer acting agonist. So these kind of a therapy will be given to the baby. So note about this neonatal abstinence syndrome. It happens whenever the patient takes the all these opioids in the pregnancy, and after delivery, you will have a withdrawal symptoms in the baby. So a persistent loud voice crying, irritable throughout the time, in the day, in the night, they're just crying. While all the babies are sleeping silently, they will be crying. Sneezing will be there. Diarrhea could be there. Whenever you see this kind of a thing in a baby, you will always think about a neonatal abstinence syndrome. Mother can have a history of a chronic pain or any kind of a trauma, and for that they will be using all these opioids. Okay, so this kind of a thing will be seen. Any doubt, please ask.
No, thank you.
Then you have a congenital torticollis. We have discussed already. It is an involuntary contraction of a group of muscles, and in this case, in case of torticollis, you will be having a contraction of sternocleidomastoids, right?
Yes.
It happens because of a malposition, okay, because of malnutrition maybe, like in case of macrosomia, like in case of any crowding, okay, and that can lead to an injury in the sternocleidomastoid. And because of that injury, fibrosis happen, and you will get an involuntary contraction because of this fibrosis in the muscle, right?
Yes.
So the step one asks you what is the cause of this congenital torticollis, you will always answer the malabsorption in utero, or maybe a malposition in utero. Okay, macrosomia, oligohydramnios, any butt trauma can do that. Okay,
Yes.
so malposition, malabsorption, they all can do it.
Why
Then you have,
malabsorption?
yeah.
Why malabsorption?
See, think about it. Whenever you have a low, you know, your fetus need things, right, in
Yeah.
order to grow. Whenever they won't get that, like in case of see the upper placenta, for example, smoking, for example, right? So this malabsorption can lead to a maldevelopment also, right?
Okay.
And this maldevelopment can lead to this kind of a thing. For example, see the case of macrosomia. In the macrosomia, the fetus will become, you know, this malabsorptive type. They
Okay.
need more nutrition, but they cannot get that nutrition, right? So this malabsorption could be relative and could be absolute.
Okay.
And relative in the thing, whenever you get a macrosomia, you will get a malabsorption, and this macrosomia can lead to this defect, right? This external defect can happen because of that. So think about it.
Oh, thank you.
So malposition, malabsorption, and fetal macrosomia, oligohydramnios, but trauma, they all can lead to the neonatal abstinence syndrome. Then you have a smoking. With the smoking, you can have a sudden infantile death syndrome. Okay. So what happens is whenever you smoke, the delivery of oxygen to the fetus will be decreased. And as a result, the fetus become hypoxemic. And if you guys, you know, and when we go forward, we have discussed about one thing, which is the hypertension in the pregnancy, right?
Yeah.
There is your the eclampsia and the preeclampsia we will discuss. And one of the cause of this preeclampsia and the eclampsia is the low oxygen in the fetal circulation, right?
Yes.
So one thing, because of this low delivery of this oxygen to the fetus, you can have a preeclampsia, hypertension. Okay. Second thing, because of this smoking, after delivery, I'm talking about after delivery, because of this smoking, you can have a second-hand smoke exposure to the baby also, right?
Yes.
The passive smoking, you call it. So because of this second-hand smoking exposure, the fetus can have, the baby can have the impaired mucociliary clearance that exactly happen in the adults. Remember the case of emphysema?
Yes.
In the emphysema also, because of smoking, you will have a chronic inflammation.
Yes.
You will have a damage in the cilia in your tract. And because of that damage, you will have an impaired mucociliary clearance.
Yes.
Impaired function of macrophages will be seen, right? Your macrophages will become activate and they will start releasing all these cytokines in response to all these smoking things, right? So you will have an inflammation in the lung tissue also. Okay, so all these three things will be seen in the adults in case of emphysema, and similar thing would be seen in the infants also. Impaired mucociliary clearance, impaired activity of macrophages, okay, and the activation of macrophages which are causing all this inflammation in the lung tissue. These three things will be seen in the baby also, and that lead to the sudden infantile death syndrome. Okay, low birth weight happen because of low oxygen delivery. Okay, recurrent otitis media episodes can happen because of impaired activity of macrophages and impaired mucociliary clearance. Respiratory diseases like the pneumonia, asthma, emphysema can also occur at a very early stage, right? So it would be a fetus who was alive an hour ago or a day ago, and now next day he just died. Okay, and the mother will have a history of smoking around the baby. So think about this sudden infant death syndrome that happens because of a smoking. Or step one can ask you this fact by giving a patient who is having a history of smoking, and they will and the step one will ask you what could be the next statement you will give to the mother. So next statement will be to stop the smoking as soon as possible, because this can lead to the sudden infant death syndrome. Is that okay?
Yes.
Yes.
Yeah.
And they will ask you why the fetus will get this thing why the fetus is having a recurrent otitis media, why the fetus is having asthma. Sorry, not the fetus, but the baby is having asthma. It is because of three things: the impaired mucociliary clearance, impaired phagocytosis activity of the macrophages, and the inflammation in the lung tissue. Remember these three things, remember these four things, okay? And all of these things are because of low oxygen delivery and a damage because of this particulate matter of the smoking, okay?
Okay.
Yes.
Now, any doubt, please ask.
No, thank you.
So
I
we
have a
will take a
question.
short, yeah.
These things will happen even if it's a second-hand smoker or only in the utero.
If you are a chronic secondhand smoker, then it can happen with you also after some time.
No, I mean for the baby.
For the baby, sorry, I didn't understand.
That pathophysiologic changes will occur in case the mother is smoking while she is pregnant or while she has a baby.
After a baby, yes. The sudden infant death syndrome occurs after delivery. Otitis media happens after delivery. Asthma, pneumonia happens after delivery. But a low birth weight, the placental abruption, which we have discussed, it happens at the time of pregnancy, okay?
Okay.
So both at the time of pregnancy and after pregnancy, you can have other things. Okay, so define. The thing we have discussed previously, all this substance abuse, it happens at the time of pregnancy. And most of the things which we have discussed here, the sudden infant death, otitis media, pneumonia, asthma, it happens after the pregnancy. Okay.
Yes, thank you.
So let's take a short break now.
Yes.
Okay, so we have discussed about this fetal alcohol syndrome, neonatal abstinence syndrome, and the sudden infantile death syndrome, smoking effects, congenital torticollis. And now let's discuss the twinnings. Okay. You have two types of twins. One is the monozygotic twins, and second is the dizygotic twins. The dizygotic twins happens whenever two eggs, okay, are fused or fertilized with two different sperms. Okay, so you call it a dizygotic twin. So both the twins, they have different characteristics. One is black, one is white, one has short hair, one is this black or brown hair. So both the twins are different, and just like two different siblings. Okay, so this is the dizygotic twins. In dizygotic twins, you have two different or separate amniotic sacs as well as two separate placenta. So a dichorionic, diamniotic, you call them. Chorion means placenta, amnion means amniotic sac. So dichorionic, diamniotic twins, you call it a dizygotic, okay? So they both have a different type of genes, okay? Although both the same appearance, but they have two different type, a set of genes, you can say, different characteristics you will find, okay? Then you have monozygotic twins in which one egg fertilized with one sperm. So both the twins will be exactly identical or copy of each other. Both the set of chromosome will be same in both the sibling. Okay, exactly identical, HLA matching, and everything will be exact same in these type of twins, monozygotic one. Okay, so if you encounter a patient, a mother, okay, who delivered one male and one female at the same time, that means are twins, what type of twins it could be?
Could you repeat once again?
You got a female, a mother who delivered one male and one female twins at the same time. Okay, what would you call them? A monozygotic or a dizygotic?
Dizygotic.
Yes, because they both, because they both have a different sex. In case of my monozygotic, they both must have a same sex as well as same characteristic, identical copy. Yes.
Yeah.
Now, why does this monozygotic twins happen? See, when the sperm fertilized with the egg, okay, you will have the formation of stem cells and other things, right? And these stem cells further form all the organs and different part of your body, right?
Yeah.
Yes.
So these stem cells has the potential to form a baby, right? A complete organism they can form, right? So if these cells separated at a very early stage, In that case, because each of these cells which are separated, they have the potential to form a complete organism. You will have the formation of two organisms, right?
Yeah.
And that exactly happens. You will have a separation, a cleavage of these cells, and individual cell will form an individual organism. You can have a separation within 0 to 4 days, within 4 to 8 days, 8 to 12 days, and after 12 days. So dependent upon at which day you are having a separation, you can have a different type of this arrangement of these fetus in the uterus. You can have a different type of arrangements, right? For example, if within 4 days separation occur, then you will have a dichorionic, diamniotic twins. They will have both a separate sac, amniotic sac, and a separate placenta within the uterus, right? If you have a separation, a cleavage, okay, after 4 days, within 4 to 8 days, in that case, you will have a monochorionic and diamniotic twins. They will have two separate embryonic this amniotic sac with a single placenta supplying both the fetus. Okay, if the cleavage happens after 8 days, that means within 8 to 12 days, in that case, the sac will be shared by both the embryos. Same sac will be shared by both the embryos with a same placenta. So you call it a monochorionic, monochorionic and amniotic twins. If the separation happens after 12 days, that means 13, 14, 15, 16, in that case, sac will be shared by both the embryos. So a monochorionic, monoamniotic again, but you will have a conjoined twins in that. Both the twins will be joined with each other. So whenever you encounter a mother who is having a conjoined twins, that means it's always going to be a case of monozygotic twins. It can never be a dizygotic. Is that okay?
Yes.
So step 1 will give you a certain thing about, in a variant, they will describe you a certain arrangement, whether it is a dichorionic, diamniotic, monochorionic, monoamniotic, monochorionic, monoamniotic, or a conjoined, and they will ask you at what stage, at what day the separation or a cleavage of these stem cells have been occurred. So dependent upon the arrangement, you will say whether it is 0-4 days, 4-8 days, or 8-12 days, or after 13 days. So know the table of 4. Okay, 4 1s are 4, 4 2s are 8, 4 3s are 12. Okay, so within first time 4, it will be a dichorionic diamniotic. Second time 4, it will be monoamniotic a monochorionic diamniotic. 3 times 4, it will be the monochorionic monoamniotic. So any doubt?
Oh, thank you.
No, thank you.
So that was about the twinning. Remember that dizygotic, it will always be a different type of twins, male, female. Either it could be male, male, but both have different shape, a different appearance. Okay. In the monozygotic, they're always identical, exact copy of each other, you can see. Then let's discuss about the placenta. So this placenta has two components. Okay, one is the fetal component and second is the maternal component. I told you when the fusion occurs and the morula forms, this morula form two structures after that. And remember the name of the structures?
Embryoblast and trophoblast.
Yeah, the embryoblast and the trophoblast. Then I told you this embryoblast again form two layers, the epiblast and the hypoblast, and the epiblast then forms ectoderm, mesoderm, ectoderm. Yes.
Yeah,
And this process is known as
Gastrulation.
gastrulation. And now you have the trophoblast. This trophoblast form two type of cells. One is the cytotrophoblast and second is the syncytotrophoblast. The inner layer is known as the cytotrophoblast and the outer layer is known as the syncytotrophoblast. Okay, so yeah, as you can see in this part, okay, if you zoom in and this part, see at this area, if you zoom in, the inner layer that you see here, this is the syncytotrophoblast, and the outer layer that you see here, this is the, this inner layer is the cytotrophoblast, and the outer layer that you see here, it is the syncytotrophoblast in this part if you zoom. Okay, now you have the maternal component, okay, which is basically derived from this endometrium of the uterus, and you call it a decidua bacillus. Now this decidua basilis forms some lacunae which are filled with the blood. So basically, you have these kind of a lacunae, okay, and all these lacunas are filled with the blood, okay. Within these lacunas, you have the blood vessels. As you can see, these are the fetal blood vessels, okay. Lining the fetal blood vessels, you have the syncyto and the cytotrophoblast. So at the one end of the syncyto-cytotrophoblast, you have the fetal circulation. On the other side of the syncyto and cytotrophoblast, you have the maternal circulation. Is that okay?
Yes.
Yes.
Now, the function of the cytotrophoblast is to form, and please note that the cyto and cytotrophoblast, they're arranged to form the villi. Okay, they are basically arranged like in these kind of orders. Okay, these kind of a villus-like structures they form, and each villus is lined by the cyto inner layer and the syncyto outer layer. Is that okay? Yeah. Now,
Yes.
what is the significance of these villi? Does anyone know?
Invasion.
Any disease? Anything you know about this villi?
Gestational trophoblastic disease.
Okay, and related to this thing,
Placenta ecquita, something like that.
any cancer? Any cancer of trophoblast, you guys know?
Choriocarcinoma.
The choriocarcinoma, yes. In case of my choriocarcinoma, I will have both the layers syncyto and cytotrophoblast, but these trophoblasts, they do not form the villi. Okay. So please
Sorry,
note, for a normal placenta, you must have the villus structures which are formed by the cyto and the syncytotrophoblast. Okay. In case of my choriocarcinoma, I have these layers syncyto and cytotrophoblast, but I do not have the villus structure. Okay, they are not organized in the villi. So if you see this cyto and cytotrophoblast which are not organized in the villi, you will always think about the choriocarcinoma. Is that okay?
Yes.
I didn't got it, sorry.
See, I told you that this syncyto and cytotrophoblast, they must be organized in the villi. See, this kind of a villi.
Okay, two types of cells.
Yeah, these two layers, in the inner layer of these villi, you have the cytotrophoblast, and the
And
outer layer you
sensation.
have the syncytotrophoblast, right?
Okay,
And they form these kind of a villus structures, finger-like projections they will form. And this is a
fine.
normal placenta. In a choriocarcinoma, you will have these two layers, but they are not forming any villus. They are just like
Okay.
linings. Okay.
Okay.
So if you see these layers, syncyto and cytotrophoblast, without any finger-like projections, you will call it a choriocarcinoma. Okay.
Okay, thank you.
So this is a very important thing to remember for the villus. So this syncyto and cytotrophoblast, they will form the villi, and the syncytotrophoblasts are actually derived from the cytotrophoblast. So they are like a stem cell layer. You can think about it like that. Okay, they form the syncytophoblast, and the function of the syncytophoblast is to release the beta HCG, right?
Yes.
And this beta HCG is similar to that of luteinizing hormone that maintains the corpus luteum in the first trimester, right? Remember?
Yes.
Now, after this first trimester, this is a syncytophoblast which take over the function of releasing the progesterone. So after first trimester, this is the syncytophoblast which is releasing the progesterone. Before first trimester, it was the corpus luteum, and the beta HCG which is released by the syncytophoblast will be stimulating it. Is that okay? Yeah.
Yes.
So all the secretory functions, it is always performed by the syncytotrophoblast. And the function of cytotrophoblast is to form the syncytotrophoblast. Okay.
Yes.
Okay.
So that was, and please note, because the syncyto and cytotrophoblast, they lacks MHC1, and as a result, the maternal immune system can never attack these layers. Step 1 can ask you this: why the fetus does not affected by the autoimmune disorders in the maternal this body? So it is because these structures, these cells, they lack the MHC1 expression. So basically, the chances of attacking by the maternal immune system will be decreased, right?
Yes.
because whenever you have an external cell or any external tissue in the body, it will always be attacked by the cells, right? So the placenta is present within the body of the this female, but is still not getting attacked by the immune cells. It is because they lack MHC1. Okay, so that is the organization of your placenta. This is the placenta. Okay, these are all arranged in the villi, as you can see. Okay, these are the villi. Okay, at the one end of this villi, you will have the cytoplasm. On the other end, you have the syncytoblast. This end, it is all filled by the metal circulation, and all these blood vessels which is present on the one side of this layer, you will have the fetal circulation. Okay, endometrial artery and endometrial vein will be supplying these lacunas. Okay, any doubt in that part, please ask.
So both cytotrophoblast and syncytotrophoblast will be in the fetal side only.
You cannot
Yes.
say whether it is the fetal side or the metal side. It is in between. Okay.
Okay.
On one side you have the metal circulation, on other side you have the fetal circulation. So they're in the between of, in the middle of them.
Okay.
But one thing is clear, that the syncytoblast is always on the outer side, that means towards the metal circulation, and the cytotrophoblast is always on the inner side, that means towards the fetal circulation.
Okay.
Okay. Now you have two things. One is the yolk sac and second is the placenta. Okay. The yolk sac will be connected to your foregut. The midgut, right? Remember?
Yeah.
The omphallomesenteric duct and the the macus reticulum.
Yes.
Right. So this is the yolk sac which supply all the nutrition to the fetus. Okay. At the very initial this stage, when the placenta is not still developed and all these things, right? So at that point, the yolk sac will be supplying all the nutrition to this fetus, and it is connected to the midgut by the omphallomesenteric duct. So this is the omphallomesenteric duct connecting my fetus to the yolk sac. Second, you have the umbilical cord, which is connecting the fetus to the placenta. And this umbilical cord contains two umbilical arteries and one umbilical vein. Umbilical arteries carries the deoxygenated blood to the placenta, and from the placenta, all this oxygenated blood will be carried by the umbilical vein. So this umbilical vein is oxygen-rich part, and the umbilical arteries are basically the oxygen-poor part. Two arteries and one vein. And does anyone know these umbilical arteries, which arteries they are branch of?
Ideal.
Internal,
Yeah.
internal
Internal.
iliacs. Internal
Yeah,
iliacs.
exactly. They are the branch of internal iliac artery. Okay. So branch of internal iliac artery, they forms the umbilical arteries. Umbilical arteries, two umbilical arteries. These blue ones that you see, these are the umbilical arteries, and they supply the deoxygenated blood here. From there, the umbilical veins will originate, supplying all the oxygen-rich blood to the fetal circulation. Is that okay?
Yes.
So all this oxygen, water, urea, waste products, hormones, okay, from the umbilical arteries, it all will be diffused into the metal circulation. From the metal circulation, all the oxygen, water, electrolytes, nutrients, hormone, IgG antibodies, which can cross the placenta, certain drugs which are very small size that can cross the placenta, viruses, they all can be transmitted to the fetal circulation into the umbilical veins. Okay. So any doubt about this placenta?
No, thank you.
No, thank you.
Okay. Now let's discuss in detail about the umbilical cord and this yolk sac and this omphallomesenteric duct and other things. So I already told you this umbilical cord, it consists of two umbilical arteries and one umbilical vein. Okay, umbilical artery, it under deoxygenated blood to the placenta again, and these are the branch of fetal internal iliac artery. Umbilical vein, which drain all the blood from the lacunas into the and drains it into the inferior vena cava. Okay, and I already told in the previous lectures, you have to bypass the liver, and that would be done by the ductus venosus. Remember?
Yes.
Now, whenever it delivers a baby, you always need to cut the placenta, right?
Yeah.
And when you cut the placenta, you always check this umbilical cord. In the umbilical cord, you always look for these two arteries and one vein. If you see single vein and single artery, It could be a sign of any congenital and chromosomal anomalies. So whenever you deliver a baby, you always need to check his or her this umbilical cord. Okay, you always look for the veins and the arteries. If you have a single umbilical artery, in that case, it could be a congenital or a chromosomal anomaly. Okay, and please note that this umbilical arteries and veins, they are all derived from the allantois. Okay, so if the step would ask you what forms the umbilical cord, what drives the umbilical cord, it will be the allantois that forms this umbilical arteries, umbilical vein, and you have this umbilical cord. Okay.
Yes.
And all of these structures, they are basically they are in this Wörthen jelly, and they're covered with this Wörthen jelly, which provide a cushion or a support or protection to these structures. In the middle, you can see there's this allantoic duct. So allantoic duct will be there. Wörthen's jelly providing all the protection to these structures. 2 umbilical arteries and 1 umbilical vein, surrounded by this amniotic epithelium. This is the umbilical cord. Any doubt, please ask.
What is the function of allantoic duct?
Allantois forms these arteries and these veins. And after that, this allantois will become the urethras, and it will connect your this urinary bladder to the yolk sac. Okay. See, the function of ophthalmophysitic duct is to connect the midgut and to the yolk sac, right?
Right.
The function of this allantois is to connect this urinary bladder and this yolk sac. Okay.
Okay.
So
Thank
let
you.
me go back again. You see the yolk sac here? It will be connected to the midgut via this omphallomesenteric duct, right? Similarly, you have the urinary bladder here. It will be connected to the outside structures, this yolk sac via the this allantois, and this allantois also it forms the umbilical cord. So all this umbilical cord formed by the allantois. Then this allantois will become the urethras. Okay, and then this urethras will be connecting this urinary bladder with this yolk sac. Okay.
Okay. Thank you.
So multiple functions.
I have a question. Where does allantois come from?
Where does this allantois comes from? I really have no idea where this comes from.
From which layer it arises from mesodome, extraembryonic.
It actually didn't
Mesodome
mention in
also.
the FA, so I really don't know which structure derived.
Okay, no problem. Thank you.
Okay. I can search it for Google. You can search it on Google and please write in the chat box so that everyone could know.
Yeah, thank you.
Okay, so that was about the umbilical cord. The second function of the allantois is to form the urethras. Okay, and the urethras will connect the urinary bladder to the umbilicus, that means to the yolk sac ultimately. So allantois, okay, it's it formed from the hindgut. It is mentioned here. Yeah, it forms from the hindgut. That means your this endoderm, of course. Okay, so allantois is derived from the endoderm. Okay, and then it extends into the urogenital sinus. Okay, in the later stage, this allantois will become the urethras. Okay, that connects the umbilicus with your urinary bladder. Okay, now at the time of birth, this allantois or this urethras, I must say, this urethras must be obliterated. Okay, and you can see the obliteration in the normal patient. It will be present as the median umbilical ligament after the birth. Okay, and that is covered by the peritoneum. Now, if this obliteration does not happen, it can lead to multiple these abnormalities. The first is the patent urethus, second is the urethral cyst, and third is the vesico-urethral diverticulum. Okay, so as you can see, this is your umbilicus part, this is your urinary bladder. Okay, and as you can see, this allantois or this urethus is connecting this urinary bladder with the umbilicus. After the birth, this part needs to be obliterated so that a connection can be stopped between these two structures, right? And this is present as the median umbilical ligament. Remember the medial umbilical ligament? I told you difference between the medial umbilical ligament and the median umbilical ligament. What
Yes.
structures form the medial umbilical ligament?
Umbilical
Umbilical
arteries.
arteries.
Yeah, just umbilical artery and umbilical vein forms the medial umbilical ligament, and this uricus forms the median umbilical ligament. Okay.
Yes.
Now, see, if this structure is not obliterated, it will be a persistent connection between the urinary bladder and the umbilicus, and you call it a patent uricus. Now, what can happen? All this urine will be discharged from this umbilicus also, right?
Yes.
Yes.
So whenever and that happens whenever you have an increased abdominal pressure. So it would be a baby who is having some kind of a straw color discharge from the umbilicus, and it happens whenever the baby cries, whenever she sneezes, or there's anything which can increase the abdominal pressure, right? So whenever it happens, patient will have a straw color discharge from the umbilicus, and whenever you see this kind of a condition, you will always think about a patent uricus. Okay. Second, you have a urachal cyst. Okay, it happens whenever you have a partial obliteration only, and as a result, it will be present between your urinary bladder and the umbilicus as a cyst. This cyst can be infected. Okay, you can have an infection in this cyst, and it will present as a pain in the abdomen, right?
Okay.
So it will be a very painful mass that present just below the umbilicus whenever it got infected with the bacteria. Third is the vesico-urachal diverticulum. Okay, as you can see, again, it will be a partial closure or a partial obliteration of this urachus. Okay, this urachus is closed at the umbilicus site, but it is not closed at this urinary bladder site, and as a result, you will have this kind of a thing, the diverticulum here, right? And it is same as that of having a Macus diverticulum. Remember?
Yes, exactly.
Yes.
And this is a true diverticulum. It contains all the layers of the urinary bladder. Okay, the muscle cell layer, the endothelial layer, the epithelial layer, the urothelium, remember?
Yes.
So uterine muscles, urothelium, everything will be present in this diverticulum. This outpouching like structure will be seen. So this is a vesico-urachal diverticulum. So any doubt about these three disorders, the patent urachus, urachal cyst, and the vesico-urachal diverticulum?
I have one question.
Yes.
Is there any kind of clinical feature associated with vesico-urachal diverticulum?
No, it would be a silent condition.
Okay. Thank
Most
you.
common, just like the Macus diverticulum, it would be a silent condition most oftenly. Okay.
Okay. Thank you.
Okay, now you have the Wittlein duct, and I told you the function of Wittlein duct is to connect the yolk sac with the embryo, right? Now, in the embryological period, just like this urachal and just like this urachus, this duct also need to be obliterated. Okay, so basically the Wittlein duct is a connection between the midgut and your yolk sac. Okay, after the 7th week of the gestation, obliteration of this Wittlein duct occur, and as a result, the connection between the midgut and this yolk sac will be stopped, right? Will be inhibited. Now, what's gonna happen? Just like your urachus, this urachus, you can have certain defects with this obliteration. If the obliteration does not happen at all, you can have a patent Wittlein duct, or you can say a Wittlein fistula will be present, and it will present as a connection between the umbilicus, a patent connection between the umbilicus and midgut. Which gut? It would be
Midgut.
midgut. Yeah. So it would be a persistent connection between the umbilicus and the midgut. As a result, just like in case of my patent urachus, you're gonna have the discharge of urine. In case of my this Wittlein fistula, you'll be having a discharge of
Feces.
meconium, right?
Oh,
Feces. So it will be a discharge of feces from the umbilicus. A solid structures will be getting discharged from the umbilicus whenever the baby cries. Okay, straining. Okay, it could lead to a discharge of meconium from the umbilicus. Think about the Wittlein fistula. Secondly, you can have a Wittlein cyst also if you have this partial closure or a partial obliteration. Just like this cyst, the urachal cyst, you can also have a Wittlein cyst, and it can get infected. Again, it will present as abdominal pain, a severe abdominal pain, just like the peritonitis, guarding, rebound tenderness, everything would be there. And a mass is present just below my umbilicus again. Okay. Third you have is the macrous diverticulum. We have discussed that already. Due to a partial closure of this vitelline duct, you will have a diverticulum or a outpouching from the midgut, right?
Yeah.
And remember the rule of 7.
Rule of 2.
Rule of 2.
Are you sure? Rule of 2 or rule of 7?
2.
2.
And where does the rule of 7 present?
Where?
We have rule of 10, and that rule of 10 is for the pheochromocytoma, right? We have a rule of 1/3. Rule of 1/3 is for the carcinoid cancers.
Oh, are you talking about Michael's diverticulum? The rule
Yes.
of 2 inches away, 2 years old.
Yeah, okay. So is what rule of 2. Okay, and what does this rule of 2 says? Anyone remember?
2 times.
2 times more likely in the male.
Yeah,
It is
Yeah,
2 inches long.
2% of the population.
Yes, and 2 feet from the ileocecal wall.
Ileocecal valve.
Yeah, so this is the rule of 2. Yeah, the rule of 2, please remember about this macrous diverticulum. This condition is again very much silent. Most patients are asymptomatic, but patient or baby or this infant can have a, this bleeding after the meconium, right? After the feces, the patient can also have a bleeding complications, right? Patient can have anemia, okay? Patient can, and because of any blockage, patient can have a, because of blockage, obstruction that can lead to the pain, peritonitis can happen, right? These are kind of rare, but the most important symptom the patient can present to with is the bleeding with,
Bleeding PR.
yeah, it's a bleeding, right, from the GI tract. So a GI bleeding will be the most important symptom that you will see. So a dark feces history will be present in the patient. Okay, that is the important thing. And complications can lead to the intersusception or any kind of inflammation. So whenever you encounter a patient having a painless bleeding in the GI tract, that means a dark stool history, anemia history, fatigue. You know, the most common presenting complaint of the anemia is always a fatigue, right?
Yes.
Yeah.
So fatigue, dark stools, anemia. Think about the macrous diverticulum if it is a child, okay? And if it is a patient after the age of 60 or 55 having anemia,
Colon cancer.
Colon cancer.
CRC,
colon
colorectal
cancer,
Colon
unless
cancer.
proven otherwise. Yes. Okay. So by giving the patient a macellum, by giving a patient with this macrous diverticulum, step 1 can also ask you what other kind of disorders can be present with a similar pathologies. So please note, it could be a vitelline fistula, it could be a vitelline sinus, it could be a vitelline duct cyst. Just like your urethral cyst, this vesico-urethral diverticulum or the patent uricus. Okay, so these two conditions are very much similar. Both are happening because of failure of obliteration. One is because of uricus, and second is because of omphallomesenteric or the vitelline duct. Allantois is derived from the endoderm structures. Allantois forming 2-3 things. One is the umbilical cord, second is uricus, and the yolk sac also. It is also formed by the allantois, right?
Yes.
So any doubt on this page, please ask.
Not on this page, but what about the rule of 7?
What was the rule of 7?
Yeah, you said there is rule of 7.
I don't
For which?
remember actually. That's why I don't remember. That's why I'm asking you. What was the rule of 7? If there is any, let me Google it.
I
Sorry
googled
about
it
that.
and I didn't find any. I already did it.
Yes. There's no rule.
No.
No rule.
Just give me a
I thought-
second. Let me check. 7 days of headache, 70 less than 70% CSF, absence of 7. There is a rule of 7, no doubt. Lyme's disease. Okay, the rule of 7 is for the Lyme's disease.
Okay.
Less than 7 days of headache, less than 70% of mononuclear cells in the CSF. Okay, or the seventh nerve palsy or other occasion of palsies. Remember the Bell's palsy, remember? In the Lyme's disease, we have discussed you can have a Bell's palsy because of Borrelia.
Yes.
Yeah.
Yeah.
That was a rule of 7. Okay.
Okay, thank you.
So any doubt on this page, please ask.
No, it's okay.
Okay, now let's discuss all these pharyngeal arches and the aortic arch derivatives. Okay, so you have 6 aortic arches: arch 1, arch 2, arch 3, arch 4. Arch 5 is obliterated, so no arch 5. And you have the arch 6. Okay, they all form the arteries from above to below again. Okay, in the very above, you have the maxillary artery, okay, which is a branch of external carotid artery, and it is formed by the first aortic arch. Second aortic arch is in the ear. In the ear, it forms the stapedial artery. Okay, in the neck, it forms the hyoid artery. Okay, the third one, it forms the common carotid and the proximal part of internal carotid artery. Okay, so if you go on this diagram, you can see this is the part, and this is the internal iliac, this internal carotid artery. This is a common carotid artery, and both of them are formed by the this third arch. Okay, first arch will be forming the maxillary artery. Second arch will be forming your in your ear stapedial artery. Third arch forming the internal carotid artery. Okay, and the common carotid artery. Similarly, go downwards. You will have a fourth arch will be forming the aortic arch, as well as the proximal part of the right subclavian artery. Okay, fourth arch forming the aortic arch and the right subclavian artery. In the sixth one, you will be having a pulmonary arteries as well as the ductus arteriosus. So step 1 can give you a patient having a patent ductus arteriosus, and they can ask you from which structure this ductus arteriosus will be derived. It will be the sixth arch. Okay, similarly, they can give you some kind of a blockage in the subclavian artery, sometimes in the right subclavian artery. Okay, any kind of a stenosis, and they will ask you from which structure this right subclavian artery will be derived. It will be your fourth arch. They can give you any patient having any atherosclerosis in the internal carotid artery, a patient having a history of transient stroke. They will ask you in which artery, which is derived from which arch you will be having the disorder. It will be in the third arch. That means the common carotid artery, internal carotid artery, right? So these kind of a patients they will give you and then ask you a very basic thing, which is the aortic arch. So for that, you need to remember which aortic arch forming which artery, okay? And please note that the left recurrent laryngeal nerve is basically loops around this ductus arteriosus, near this ductus arteriosus. And very close with the pulmonary arteries and with the which part of atria?
Left atria.
Yes, the left atria. Okay, so because just give me a second. Yeah, because the left atria is the most posterior structure, and what is the most anterior structure?
Right ventricle.
The right ventricle. Yes. Okay, so remember that also. Similarly, the right recurrent laryngeal nerve, it basically loops around this subclavian artery. Okay, right subclavian artery, and as a result, it won't be compressed whenever you get a dilation of the left atria. So it will be almost every time it will be a left recurrent laryngeal nerve that can get compressed whenever you have any problem with the heart. Okay.
Yes.
Okay.
Okay.
So any doubt on this aortic arch, these derivatives?
No, thank you.
Okay, now you have the pharyngeal apparatus. So one is the aortic arch apparatus, and this aortic arches, and second is the pharyngeal apparatus. Multiple layers will form this apparatus: ectoderm, mesoderm, endoderm. All these structures you see on your face, on your neck, they are all derived by this pharyngeal apparatus. You have three things. On the outermost side, it will be the clefts. In the middle, it will be the arches. In the innermost side, it will be the pouches. And similarly, the outermost structures are formed by the ectoderm, which is the outermost layer. The middle structures are formed by the mesoderm as well as the neurocristals. Neurocristals forming all the bones and the cartilages. Okay, and the muscles and arteries are formed by the mesoderm. Okay, innermost structures formed by the innermost layer, that means the endoderm. Okay,
Yes.
Yeah.
so you have 6 arches again, just like the aortic arches. You have 6 arches: the arch 1, arch 2, arch 3, arch 4, and arch 6. Fifth arch is obliterated; it do not form any structure. In every arch, you can have a cartilage, you will have a nerve, and you will have an artery. And please note, nerves are not driven by this pharyngeal apparatus, but instead these nerves are supplying here. Is that okay?
No, sorry.
See, the arteries, the cartilage, they are all driven by this pharyngeal apparatus. Okay, but the nerves, they are not driven by this apparatus. Instead, these nerves are supplying here. Okay.
Okay, just mentioned there, you mean?
Yeah.
It's just mentioned a diagram, you mean?
Sorry, I didn't understand.
You mean that the nerve is just mentioned on the figure, on the diagram?
Yeah.
Yeah,
They are
okay.
wrong. No, they are not. Sorry. I'm not getting you actually.
Sorry.
Repeat it again if you can, please.
You mean that the nerve only mentioned in the diagram, not any of its origin or its
Yeah, it has not. The origin of nerve is not from the pharyngeal apparatus. The origin is from the neuroectoderm and from the neurocrest cells in the brain and the spinal cord, right?
okay.
And from the brain and from the spinal cord, these nerves are supplying here. So whatever nerve you study later, okay, the 5th nerve, the 7th nerve, 9th nerve, and 10th nerve, they're not originating from the apparatus. Instead, they're supplying this apparatus. Okay.
Okay.
Would you mind to zoom little? I want to see what you have annotated over there.
And this orange pen.
Yeah. Thank you.
That's all we have discussed already. The pouch and this cleft and the arch, and all these pouches will disappear. We'll discuss it later. Don't worry.
Okay, thank you. I missed it. Okay, thank you.
Yeah, everything will come later. Don't worry about that. So first, let's discuss about these arches, these clefts, which are the outermost structure. They're derived from, all of them are derived by the ectoderm. Okay, you have 1, 2, 3, and 4. Please note the cleft from 2 to 4. Okay, they will be kind of obliterated in the fetal life, so they do not form any structure. But this first cleft, it forms the external auditory meatus. So the external ear is formed by the first cleft. And I told you, whatever structure you see from outside, it is altered by the ectoderm, right?
Yes.
Yes.
So you can remember it by this fact that this first cleft, it actually forms the external auditory meatus. Rest all of the clefts from 2 to 4, they will be obliterated in the fetal life. Okay, now if these clefts are persistent, okay, then they will form the sinuses there. They will form, and that can lead to the persistent cervical sinus. Okay, they will form the brachial, this cleft cyst that you guys know the disease. Okay, so basically, whenever these 2nd to 4th cleft, if they are not obliterated, they will form a cyst-like structure, a mass. Okay, which is filled with this all things. A cystic mass they will form, and they will present on the lateral side of your neck. Okay.
Yeah.
And please note the location. They will be present in the anterior to the sternocleidomastoid muscle. Step 1 will ask you the location, where in the lateral neck, and the anterior part of your sternocleidomastoid. These are the brachial cleft cyst. You also have the thyroglossal duct cyst, remember?
Yeah.
And this thyroglossal duct cyst will be present in the midline, right?
Yes.
And one more cyst you have in the midline, remember the name?
Yes, thyroglossal cyst.
Yeah, we have encountered it already. Other than that thyroglossal duct cyst, also have a cyst in the midline.
Regular cleft cyst?
Which?
Thyroid disorder, thyroid gland.
You already have a thyroid duct cyst. Other than this thyroid duct cyst, dermoid cyst, remember?
Dermoid?
Dermoid cyst, in which we am rampant of this skin layers, hairs, skin, adipose tissue, epidermis, hypodermis.
Okay, that can be there.
Okay. Yeah, and these structures will form a cyst in the midline. You call it a dermoid cyst. So how will you differentiate between a thyroglossal duct cyst and a dermoid cyst? We have discussed that already in the endocrine.
The thyroglossal duct cyst will move with the swallowing.
Yeah, but the dermoid cyst won't move with the swallowing. This
Yes.
thyroglossal duct cyst will present in the very early part of your delivery. After, in the infant stage, it will be present. But this dermoid cyst can happen in the adults in a later life, right?
Okay.
So that's why we'll differentiate between the brachial cleft cyst, between the thyroglossal duct cyst, and between the dermoid cyst. Okay, the brachial cleft cyst will be found on the lateral side of your neck. Okay, just anterior to the sternocleidomastoid. Thyroglossal duct cyst will be found in the midline. Okay, it will move with the swallowing, and it will present early after the birth. Versus the dermoid cyst, it will found in the early childhood or in the adulthood, not soon after the birth, and it won't move with the swallowing, right?
Yes.
So step 1 will ask you why this brachial cleft cyst is forming. It will be because of improper obliteration of the second, third, and fourth pharyngeal clefts. Any doubt, please ask.
Is the dermoid cyst also capable of swelling up during sickness?
Sorry, ask it again, please. Dermoid
Some,
cyst is capable of?
okay, sinuses, like these extra sinuses will swell up during sickness.
During infection.
Yeah, during infection. And that's like when you will note that these cervical sinuses occur. Is that something?
These cysts are actually filled with some kind of a fluid. You can think about like that, or they may be empty. But a dermoid cyst is a solid one. Okay.
Okay. Okay.
So basically, chances of infection is more in the thyroglossal duct cyst or in this cyst, the brachial cleft cyst. But the chances of infection is less in the dermoid cyst.
Okay, but that's one question. My second question is the thyroid cyst a type of cervical sinus, or is that a completely different thing?
Thyroid cyst is a part of cervical sinus, you're asking?
Okay, there are 3 different types of cysts. There's
Yes.
there's the cervical sinus, my dermoid,
Yeah.
and my thyroglossal. Is that what's happening?
You're asking whether this thyroglossal duct cyst is a part of the cervical sinus.
Yeah, if it's like a specific type of
No.
it.
These both are different. Remember this duct, the thyroglossal duct, which is formed from your which part on the tongue?
Foramen and cecum.
The foramen and cecum, remember?
Yeah.
So these are different things, okay? The
Okay.
persistent cervical sinuses are different, okay? These are the clefts you can see. The clefts or sinus.
Mm-hmm.
You can call them both. So they will form the lateral cyst. Central cysts are different, formed by thyroglossal duct, which is a different thing, not the cervical sinuses, okay?
Okay. Yeah. And then my dermoid cysts can occur anywhere, right? They don't have to be superior or lateral. Okay.
Yeah, it can be occur anywhere in the midline neck.
Okay. Thank you.
So any more doubt on this page?
No, thank you.
Okay. So remember about this pharyngeal apparatus, pharyngeal arches. Okay, these pharyngeal arches develop into the aortic arch, forming the arteries we have discussed already. Okay, in the pharyngeal apparatus, you have the clefts or the sinuses, forming the pharyngeal clefts and sinuses, and they will be taking part in the formation of your external ear, and they will be obliterated later, second to fourth. If they are not obliterated, then they will form this cyst, brachial cleft cyst. Now let's discuss other structures other than the arteries. All these arches are forming. Okay, so the first arch is here, and and you will see the upper face. Think about the upper face. That means the maxillary bone, the zygomatic bone, okay, and the mandible. So the upper part of the face is already formed by this. It's all formed by this first pharyngeal arch. Okay, so maxillary, zygomatic, and mandible bone. These are formed by the first arch. Okay, and the malleus incus is also formed by the first arch. So for the bones and the cartilage, you're having the maxillary bones, zygomatic bone, mandible bone, malleus and incus. All of them are started by this M, right?
Yes.
Yeah.
Okay. And you can remember this by the fact that this first arch is supplied by the mandibular nerve. Okay.
Yeah.
So because this mandibular nerve is supplying this arch, so that's why this mandibular nerve is also supplying your mandible. Okay. And I told you that in ear, you also have this nerve supplying the malleus and incus, remember?
Yeah.
For the muscles, I told you that this mandibular nerve is take part in the chewing, and all the muscles of mastications are supplied by this nerve, right?
Right.
Yes.
So you can easily remember what muscles are going to drive from this first arch. These are the muscles of mastication, the temporalis, the middle pterygoid, lateral pterygoid, masseters, right? And the anterior 2/3 of the tongue also, it is supplied by the, sorry, it is formed by this first pharyngeal arch. Is that okay?
Yeah.
Yes.
The arch,
So if you cannot remember all these names, you can just remember about this mandibular nerve. Okay, the mandibular nerve, what structures this mandibular nerve was supplying, these are all driven by the first pharyngeal arch. Now doubt, please ask.
arch is the middle part of the pharyngeal body, right?
Arch is the,
The middle part.
yeah, the middle part is the
base.
arch, yes.
Okay.
Outermost you have the cleft or the sinuses, middle one you have the arches, on the inner side you have the pouches.
Okay. So it's the mesoderm, the connective tissue, the form bone and muscle.
Yeah, exactly. All the mesoderm structures, this mesoderm layer will forming your muscles. Okay.
Okay.
Now, one disorder which is associated with this first pharyngeal arch defect, and this is the Pierre-Robin sequence. And please note, it is again a sequence. Now, what's happening in this sequence? First thing, you're having a micrognathia. That means a smaller jaw, because you know that this first arch is forming all the structures of your jaw, right? The mandible.
Yes.
So if any kind of a defect happens in this arch, you will have a shorter or a smaller jaw, and that is known as the micrognathia, right?
Yes.
Now, due to this smaller jaw, you will be having a posterior deviation of the tongue. Posterior and upward deviation of the tongue happens. Just above the tongue, you have the palates, right? That need to be fused. Okay.
Yeah.
Now, if the backward and upward deviation of the tongue happens, you cannot get the fusion of these palates.
Yeah.
Let us suppose you're having this is your jaw. You're having these palates here, and you're having the tongue here. This is a normal scenario, right? Yes.
Yes.
Because
Yes.
of a shorter jaw, right? What thing will happen is you'll be having a posterior and upward deviation of the tongue. Okay, and
Yes.
as a result, it will interfere with the palates also. This is your palate, and now these palates cannot be fused because the tongue is present here, right?
Yes.
So what you will have is the cleft palate defect, not the lip, but the palate defect. Okay, because the palates now cannot fuse because the tongue is present here. Okay, that's the first thing. Because of posterior deviation of the tongue, you will also have the airway obstruction, right?
Yes.
So one thing is the obstruction. Patient will have a respiratory distress. He cannot inspire the air. Baby cannot inspire the air. Second thing, you will be having a cleft palate defect. And please note, it will be a U-shaped palate. Let us suppose this is a normal, this is a roof of your cavity, and these are the palates present here, fused. In the patient having a glossoptosis, right? That means a posterior deviation of the tongue will occupy this part, right?
Okay.
And because of that, in these areas, these palates cannot be fused. So it will be like having this thing, right? So a U-shaped palate defect will be present. Okay.
Okay.
Yes.
Having any doubt about this thing?
No. Thank you.
Okay, so this is a Pierre-Robin sequence. Again, a sequence, because one thing that is a macrognathia is leading to other defects like the glossoptosis, and that is leading to a cleft lip and the airway obstruction. So whenever I encounter a patient having a respiratory distress, this means a very high breathing rate, a difficult to inspiring the air, having a U-shaped palate defect, having a very smaller jaw, and a posterior deviated tongue, always think about the Pierre-Robin sequence, and that is a defect in the first pharyngeal arch. Okay. Now you have the second pharyngeal arch, which is supplied by the seventh nerve. So because seventh nerve is supplying this arch, so all the structures which are formed from this arch will be supplied by the seventh nerve. So for the cartilage, for the bones, you know that the seventh nerve supplies the stapes, right? Stelloid process. Lesser horn of the hyoid is also supplied by this nerve. So stapes, this stelloid process, and the lesser horn, all of them has a S in them. Okay, so it is supplied by the seventh nerve or the second pharyngeal arch. Similarly, I told you that this seventh nerve is responsible for the expression of your face, right?
Yes.
So all the muscles which are involved in the facial expression, the stapedius, stelloid, platysma, posterior belly of digastric, they're all supplied by the seventh nerve, and that means they're formed by the second pharyngeal arch. Okay.
Yes.
Now, a combined defect of first arch and the second arch can lead to a teacher-Collin syndrome, and it is a syndrome where one defect is leading to multiple other defects. Okay, because of an autosomal dominant mutation, you will be having a neural crust dysfunctions. And I told you that in the arches, to go back, I told you in the arches, the neural crust cells are forming the bones and the cartilage, right? So if a dysfunction in the neural crust cells happen, it can lead to a developmental defect in all the bones which are formed by this first arch and the second arch, right?
Yes.
So you will be having a neural crust dysfunction that is leading to a craniofacial abnormalities. You will be having a hypoplasia of the zygomatic bone, mandibular bone. Because of this loss of malleus incus and stapes, you will be having a hearing loss. Hyoid bone will be lost. Okay, and that will lead to an airway compromisation also. So a hypoplasia of the zygomatic bone, a mid-face hypoplasia, it could be mandibular hypoplasia, micrognathia, again you will be having. Okay, airway obstruction you will be having, hearing loss you will be having, right? All of these things will be present in the teacher's Collin syndrome, the teacher-Collins syndrome. Okay. Yeah.
Yes.
So please note the Pierre-Robin sequence, which is because of a first pharyngeal arch, teacher-Collin syndrome because of both the mutation in the first arch as well as in the second arch. Hypoplasia of all the bones will happen. Okay. Now you have the third arch, and it is supplied by the ninth nerve. Okay. For the nerve, for the bone, this nerve is supplying the greater horn of this hyoid bone. So the lesser horn for the second arch, greater horn for the third arch, and that is the only bone which is supplied by this, which is formed by this third pharyngeal arch supplied by the ninth nerve. For the muscles, you guys know that the stylopharyngeus muscle is supplied by the ninth nerve. Okay, and rest of all the muscles, I told you that it is all supplied by the glossopharyngeal, hypoglossal nerve. Remember the 12th nerve?
Yes.
So only the one muscle, that is the stylopharyngeus, supplied by the ninth nerve, which is a glossopharyngeal nerve. Rest all the muscles of the tongue is supplied by the 12th nerve, which is a hypoglossal nerve. Okay.
Yes.
So for the third arch, the bone is the hyoid, muscle is the stylopharyngeus, and nerve supplies there is the ninth nerve. Okay. Then you have the fourth and the sixth pharyngeal arches. They are all forming the similar structures. Same structures formed by two different arches. Okay, like every this. Just give me a second. Yeah, the voice box, okay, all the cartilage which is present in the voice box, they are all derived by the fourth and the sixth pharyngeal arches. Okay, the thyroid cartilage in the voice box, it is formed by the fourth arch, and rest all the cartilages, arytenoid, carotid, this cricoid, arytenoid, the cornulate, and the cuneiform, right? All of the remaining cartilages in the voice box are formed by the sixth nerve. So just remember about the thyroid. You can forget the rest, which is obvious thing. The thyroid is formed by the fourth nerve. Rest all remaining cartilage in the voice box is formed by the sixth pharyngeal arch. Okay, the fourth arch is supplied by the 10th nerve, and the sixth arch is also supplied by the 10th nerve. But the superior laryngeal nerve is supplying the fourth arch, and the recurrent laryngeal nerve is supplying the sixth arch. Is that okay? I told you about this 10th nerve, vagus nerve, that is forming, this superior and the inferior nerve. Remember, the superior one will be forming two branches, the exterior and the interior laryngeal branch. Remember,
Yes.
exterior one supplying the voice box, and the interior one is a sensory branch, right?
Yes.
The piriformis fossa.
Yeah.
And after going downwards, this vagus nerve gives off another branch, which is the recurrent laryngeal nerve, right? So recurrent laryngeal nerve supplying the sixth arch, and the superior laryngeal nerve supplying the fourth arch. I told you that only one muscle of the voice box is supplied by the superior laryngeal nerve, this nerve. Remember? And there is a cricothyroid muscle, right?
Yes.
And rest all the muscles of the voice box is supplied by the recurrent laryngeal nerve. What happens whenever you got a damage in the superior laryngeal nerve?
Hoarseness.
No, hoarseness happens after the recurrent laryngeal nerve pulsing.
Superior.
Aspiration.
That again happens because of this recurrent laryngeal nerve. I told you every muscle in the voice box is supplied by the recurrent laryngeal nerve except one, which is the cricothyroid, and that gives your voice a tenor, right? The loss of voice tenor will happen.
Loss of what?
Okay. Loss of voice tenor will happen whenever you got a damage in the superior laryngeal nerve.
Okay.
And that is seen in the musicians, right? Singers, that will be seen in. Okay.
Okay.
So remember about the function of the superior laryngeal nerve supplying the cricothyroid muscle. Okay. And whenever damage happens, you will have a loss of voice tenure. Rest all of the muscles are supplied by the recurrent laryngeal nerve. Okay. Whenever a palsy or damage happens, you will get this hoarseness in the voice, and you will also get the respiratory distress, right? Because air now cannot be passed through this voice box. Okay.
Okay.
And again, the fourth arch is supplied by the superior laryngeal nerve, and I told you that thyroid cartilage and the cricothyroid muscle is formed by the fourth arch. Rest all the muscles and all the cartilage is formed by the sixth arch. Is that okay?
Yes.
Yes.
Now, if you again think about it, the 12th nerve and the 10th nerve, this 9th nerve and the 10th nerve supplying the posterior 1/3 of the tongue also, right?
Yes.
Yes.
So the posterior 1/3 of the tongue is derived from the third arch and the fourth arch. Okay.
Yes.
So instead of remembering all these structures formed by these arches, you can just remember about these nerves. First arch, which this fifth nerve, second arch, seventh nerve, third arch, ninth nerve, fourth and sixth arch, 10th nerve. And then already know in the neurology, we have discussed all the functions of these nerves. So you can easily know what structures are going to be supplied by these nerves, and similar structures will be forming by this first, second, third, fourth, or sixth arches. So remember it like that instead of learning, with the respective arches. Think about the nerve first. Think about the muscles this nerve are supplying, cartilage these nerves are supplying, and you can immediately know what arch is which arch is forming these structures. Okay.
Yes.
So any doubt on the pharyngeal arch derivatives, please ask.
No, thank you.
Okay. Now, I told you already that the sensory and the motor nerves, these are not derived in the laryngeal arches. They're supplying these arches. They're all derived by the neural crus cells or the neuroectoderm. And please note, the sensory part of these nerves supplying the pharyngeal arches, it is formed by the neural crus cells, and the motor part is formed by the neuroectoderm layer. and that is a very high yield thing. Okay, motor part, neuroectoderm, and the sensory part is the neurocrist cells. And if you guys remember about the alar plate and the basal plate, remember?
Yeah.
And what is what is alar and the basal plate? If yes, then
Spinal cord formation.
not just a spinal cord, but all the nerves formation
Brainstem.
also. All the nerves formation, yes. So what nerve is derived by the alar plate and what nerve is derived from the basal plate?
Alar dorsal.
Sensory one is alar.
Sensory. Alar dorsal.
Yeah, alar is dorsal, that means sensory, and basal is motor, that means anterior, right?
Ventral.
Oh,
The anterior, you can say ventral part, that means the basal, motor, dorsal part, sensory, okay, derived from the alar plate, okay.
Yes. Yes.
And which genes or what other things forming these alar and the motor plates, if you guys remember?
Saanich Hedgehog.
Okay, sonic hedgehog forming which plate?
I think the
Basal. Basal.
Yeah, basal plate, yes. And the alar plate?
Hogs.
say hog.
Not the hogs. No, not
BMP.
the no. Think more. A very unusual thing. TGF beta.
TGF beta. Yes.
Very unusual, right?
Mhm.
So TGF beta forming the basal plate, alar plate, and sonic hedgehog forming the basal plate. Okay, and again these plates, that means the alar plate will be supplying the sensory part, and the motor plate, which means the basal plate, supplying the motor structures derived from the neuroectoderms in this case. Okay, and all the sensory nerves are derived from the neural crest cells. Okay.
Yes.
There is a point, please.
Yeah.
Is that not to emphasize that muscle and bone are pharyngeal are derivatives, right? But
Yes,
nerves
muscles
are
and
not. Yes,
repeat it again, please.
I'm slightly confused. That note, that the last note.
What
Okay.
is the last note? This one.
Yeah, has to emphasize that pharyngeal arch gives only the muscles and bones, right?
Muscle, bones, and arteries.
So what about the third column, nerve column here? Where it come from?
These nerves.
Yeah.
Nerves column.
Yes. Is
I
it
told you
about?
nerves are not originate from here. They're supplying here.
Oh,
Okay.
okay. I missed that. Okay. Sorry,
Yeah,
I missed it.
Yeah, nerves are not originated from here. They're supplying these structures. Muscles, bones, and arteries are originated from here. Okay.
Okay, and that not emphasize that.
What about?
Okay, that the last note has to confirm that.
When the restaurants of the
No, the
this part,
highlighted one.
this one.
Yes. Yeah, confirms that the nerve are not a part of derivatives.
Yeah, exactly. The sensory and the motor nerves, they are not the pharyngeal arch derivatives. They are supplying these structures that I told you before, right?
Okay,
They're
that's
all
the point
the sensory and the sensory and motor nerves. They're formed by the sensory part is formed by the neurocrist cells, and the motor nerves are formed by the neuroectoderm cells. Okay.
Okay, thank you. Sorry.
Yeah. So any more doubt on this arches? Very important to note. You can expect at least 1 or 2 questions from these arches for sure. A very high yield topic it is. So please note, please ask if there's any doubt. No?
Could you repeat what you said about superior laryngeal branch?
See, let me draw this diagram for you. Okay. You have this vagus nerve originated from the brainstem, okay, descending downwards. Okay. While descending downwards, near your voice box, it gives up two branches. Okay.
Yes.
One branch first, which is superior laryngeal nerve. This superior laryngeal nerves gives up two branches, outer or external and inner one. So external superior laryngeal nerve and the internal superior laryngeal nerve. Okay.
Yes.
The outer nerve, it is supplying the motor part, and the inner one supplying the sensory part. Okay.
Yes.
Now, while descending downwards again, it gives off another branch, and that is a recurrent laryngeal nerve. Okay.
Yes.
Ascending upward. Now, the motor part, this motor part of the superior laryngeal nerve, it supplies the cricothyroid nerve. Sorry, this muscle, the cricothyroid muscle. Okay.
Yes.
And rest all of the muscles of your voice box is supplied by the recurrent laryngeal nerve. Okay.
Yes.
So whenever you have a damage of the superior laryngeal nerve, because you know this nerve is lying a very close association with the superior laryngeal artery. You have the artery here also. Okay. So while doing the thyroid surgery, if you ligate this artery, by ligating, you can also damage this nerve.
Okay. Yes.
If this nerve got damaged, you will get a loss of voice tenure because this nerve is supplying the cricothyroid muscle.
Yes. Got
Okay.
it. Yes.
Now, second thing, you also have this inferior laryngeal while ligating this inferior this thyroid artery, you can also damage this recurrent laryngeal nerve, right?
Yes. Yes.
And whenever this damage happens, you will get a loss of all the muscles which are supplied by this recurrent laryngeal nerve. You will get a hoarseness in the voice.
Yes. Yes.
And you will also get a respiratory compromise because of that, because now no air cannot pass through your
Yes.
the voice box, right?
Yes.
So that's about it. And please note that this superior laryngeal nerve, it is supplying the fourth arch. Okay. And that's how you know that this cricothyroid muscle, thyroid bone, okay, they are forming and they're formed by the fourth arch. Okay. Rest all the muscles and all the arches, and all the bones, okay, they are all driven by the sixth arch of your voice box. Okay.
Okay. Thank you.
So just know the nerves first, and from the nerves, go to all these structures and then to the arches. This way, and it would be easier for you to learn, right?
Okay. Thank you.
Any more doubt, please ask.
No, thank you.
Okay. And you guys also know about this gag reflex, right? The cuff reflex and the gag reflex.
Yes.
So the sensory branch, I told you about superior laryngeal nerve. The sensory branch will take part in which part? In which reflex? Gag reflex or this cuff reflex?
The cough reflex.
Huh?
Isn't it the you gag by 9, you cough by 10, and by 10?
You tell me. I got a blockage in the sensory branch of this superior laryngeal artery, this nerve. Okay. So I could lose this gag reflex or the cuff reflex.
Gag reflex.
Okay. Why not the cuff reflex?
Should be.
I have the involvement of 10th nerve in the cuff reflex also. Why not the cuff reflex? Why just the gag?
Because for gag you have glossopharyngeal as well and vagus nerve.
For the gag, yes. So see, no, we're talking opposite, right? So see, cuff reflex will be lost, but gag reflex will be normal if you got a damage of the superior laryngeal nerve. Okay. So now tell me, why not this gag reflex also? That's a question. I got it confused, sorry, initially.
Because gag reflex is by 9.
Because gag reflex is?
Supplied also by the glossopharyngeal nerve.
It not all, yeah, it also takes part in it. So what? If it is
So
taking part?
if one nerve is damaged, the other one will be functioning.
No, that's not the thing actually. See, you're talking, you're saying it right that you have two nerves. One is the 10th nerve and one is the 9th nerve, right?
Yes.
you have two limbs for every reflex. One is the afferent limb and one is the efferent limb, right?
Yes, yes.
The function of afferent limb is to take the senses,
Yeah, to the central
and the
nervous system. Yes.
yeah, and the function of efferent nerve is to take all the information from CNS to the periphery. That means the motor
Yeah.
part.
Yes.
Yes.
I told you that for the sensory part, for sensory part in the gag reflex, you have ninth nerve, and for the motor part, you have the 10th nerve, right? It's not that both the nerves are supplying both the sensory as well as the motor part. Okay, one nerve for the motor and one nerve for the sensory. Okay.
Yes.
Now, if you're damaging your superior laryngeal nerve, which is a sensory nerve, this inner part, okay, in that case, I will lose a sensory limb, right? Not the motor limb.
Okay. Okay.
The
Okay.
sensory limb in my gag reflex is by the 9th nerve, not by the 10th nerve. But
Yes.
the sensory limb in my cuff reflex is by the 10th nerve.
By 10th. Okay.
That's why I will lose only the gag reflex. I will lose the cuff reflex only, not the gag reflex, right?
Okay.
So step 1 can ask you this fact. It will be a patient on a thyroid surgery, a thyroid removal surgery, and he suddenly got the damage of this sensory nerve, or maybe because this nerve is lying in the piriformis fossa. If you have any kind of obstruction there, it can damage your nerve there, right? The sensory nerve. So they will ask you what reflex will be lost. Both the options will be there: gag reflex and cuff reflex, and you have to answer the cuff reflex, not the gag one, because the gag part, the sensory nerve is the 9th nerve, not the 10th. Okay.
Okay. Yes. Thank you.
Okay, so we have discussed the clefts or the sinuses. We have discussed the arches, and now the term for your pouches. Okay, the pouches will be supplied by your endoderm, right? The first pouch, this first pouch, just like the cleft and just like my arch, just like that, the first pouch will be taking part in the formation of ear. Okay, the cleft will be forming the outer part. Okay, the middle ear cavity will be forming by this first pouch. Okay, and the eustachian tube, it will be forming by your first pouch again. Mastoid air cells will also be formed by the first pouch. So for every first pouch, you will always think about the ear. Okay. The cleft will be forming the outermost. That means your the ear canal. Okay. This cleft. Okay. And the arch will be forming the malleus incus, a part of the middle the middle ear cavity. Okay. And the first pouch will be forming the other structures which are present in the middle ear cavity. Okay. It's taking tube, it will be forming, and mastoid ear cells, it will be forming. Is that okay?
Yes.
Yes.
Then you have the second pouch that will be forming your palatine tonsils. Okay. So whenever you have a tonsillitis, having a hypertrophy of these tonsils, step 1 can ask you from what structures these tonsils are derived. In case of tonsillitis, they will ask you this. So please note, a second pharyngeal pouch will be forming these tonsils. Third pharyngeal pouch will be forming the inferior parathyroid. Okay. And the thymus also. Okay. So whenever you have a DiGeorge syndrome where you have a thymic aplasia, I told you that in case of DiGeorge syndrome, you'll be having a degeneration of third pharyngeal pouch, right? And the fourth one also. Remember?
Yes. Yes.
Yes.
So that's why in your DiGeorge syndrome, you can have, because of a damage of this third and fourth pharyngeal pouch, you will be having a loss of parathyroid glands as well as the thymus gland, right? The thymic aplasia and the loss of parathyroids you will see. Similarly, this fourth pharyngeal this pouch will be forming the superior parathyroid. This is important. Although third pharyngeal pouch is above the fourth, but still the third pharyngeal this pouch will be forming the inferior parathyroid, and the fourth pouch, which is below, forming the superior parathyroid. Okay, and
Yes.
other than that, this fourth pouch is also forming the parafollicular C cells of the thyroid. Okay.
Okay.
So note that fact also. So for the first pouch, ear, think about it. For the second pouch, think about the tonsils. For the third pouch, think about the parathyroid and thymus, inferior parathyroid and the thymus. For the fourth pouch, think about the parathyroid as well as the this superior the parathyroid as well as this follicular C cells, parafollicular C cells of the thyroid. Okay. So I told you initially when we were discussing all these layers, I told that the endoderm is forming the thyroid as well as parafollicular C cells. Remember?
Yes.
Yeah.
that was, I mean, okay, this thyroid gland, the follicular cells, okay, they are all formed by the endoderm, which is because of outpouching of the endoderm. Okay, the parafollicular C cells are formed by the pharyngeal pouches, okay, which are formed by the endoderm again. So that's why the whole thyroid is endodermal derived, whole parathyroid is endodermally derived, thymus is endodermally derived. Okay, the middle ear cavity is endodermally derived, while the external ear, okay, that means your ear, this ear canal and the pinna is all derived by the ectoderm. Okay.
Yes.
Okay.
Yes.
Remember about the DiGeorge syndrome, in which you're having a loss of this third and fourth pharyngeal pouch, and that's why you're having a hypoparathyroidism as well as thymic aplasia. Okay. So any doubt
Okay.
on the pouches, please ask.
Yes, please. Superior parathyroid will move upward or will stay in its location?
See, what happens is initially when you have the formation of this thyroid, this parathyroids, you have third pouch here, let us suppose, and the fourth pouch here. Okay. They form these inferior thyroid, inferior parathyroid, and the superior parathyroid. But what happens is initially it will be like that, but both of them need to descend at their respective locations, right? While descending, these superior ones will move downward, more downward than the inferior ones, and as a result, after the birth, those ones who are and those ones who are superior, they will become ultimately inferior. It's all because of downward movement of them, right?
Okay.
Yes.
So
Similarly, the thymus also need to go downward after the formation and need to be located in the neck. Okay.
Okay.
It's all because
So
of their
let's-
movement. They move more than these inferior ones. Yes.
Okay. Okay. Thanks.
Okay. So that's about these pouches. Any more doubt, please ask.
No, thank you.
Let's take a short break of 5 minutes. Then we will finish this cleft lip and palate. Okay.
Yes.
Okay. 5 or 10 minutes max.